and via email. If you happen to have a question while we're going through things, I know this is a little bit different than the real deal class, but you all know that you're not interrupting me by any means. So feel free to throw something in the chat box. You're welcome to unmute your microphone, and again, don't feel like you're going to cut me off or interrupt me. If you have a question, stop me and ask, and we can talk about things from that point forward. So without further ado, unless anybody has any pressing questions before we get started, we will try to catch up where we left off at the other day. I believe we got around humidification because I remember going over this in class with the neck flexion and the extension. I believe we talked about the Adam's apple, the thyroid cartilage, where that's found out with the larynx. Yeah, because I remember talking about where you would stick the intubation, the laryngoscope handle, not the laryngoscope handle itself, but the laryngoscope blade. So when once we get to inserting an artificial airway, some of the anatomical landmarks that you're going to need to be aware of, and hopefully you can see my cursor on the screen, but you obviously so uh, my uh, just so you, I'm just going to navigate away from this for a second, just so you can kind of see the differences in what I'm talking about. Because I know if you've never seen it, um, it may be a little odd to be able to determine what it is that I'm talking about. But we'll see if Google will do its thing and help me out. Miller intubation blade. Whoops. So that's what a Miller blade looks like. It's straight. So when I mention Miller blade here in a little bit, when I go back to that graphic, or when I go back to the PowerPoint, this is what I'm talking about. And then we have a Macintosh intubation blade, and it's curved. You should be able to see, yeah, and you'll notice how that's different from what we had looked at just a little bit. It's curved. So now if we navigate back to our PowerPoint, and we'll go from the current slide. If you're utilizing that Miller blade, the straight blade, you will physically, after you insert it into the mouth, get toward the base of the tongue, you'll physically, so if my pinky is the Miller blade, you'll physically lift the epiglottis with that to visualize the vocal cords that are coming underneath that. If you utilize that Macintosh blade, it's curved, and notice that curve is going to follow the curvature of the airway. So ultimately, what you'll do now is that Macintosh blade, you'll slip toward the base of the tongue, but rather than directly lifting the epiglottis with that Macintosh blade, the space above the epiglottis is called the vallecula. So you'll insert that blade into the vallecula. And when you do that, it actually lifts the epiglottis. So when you press into there, it lifts the epiglottis, and then that'll allow you to visualize the vocal cords below that. It's going to be a little while before you get to doing endotracheal intubation. By a little while, you get knocked out this semester, and then I think it's uh probably one of the first competency evaluations you'll do in the summer, aside from EKGs and arterial blood gases. So within the first couple of weeks of the summer semester, you guys should be checked off on endotracheal intubation and supplemental adjuncts such as laryngeal mask airways and things like that. And I know this isn't the class to speak about that, but as we're going over the anatomy, just to try to stress upon you the importance of these anatomical structures, because these are things that you're going to want to remember moving forward, because these are uh, things that you're going to either want to avoid hitting, or the areas in which you're going to be aiming with that endotracheal tube uh, once you get uh, once you get to that point. So vallecula is a space between the epiglottis and the base of the tongue. That is going to be an important landmark for endotracheal intubation, specifically placement of the type of blade. So you'll lift the epiglottis with the Miller blade. You're aiming for the vallecula if you're utilizing the Macintosh blade, and that'll be important to be able to remember moving forward. We did talk about those cartilages and so forth. So you've got the thyroid cartilage, which is this large cartilage right here. Uh, And that is the component that is your Adam's apple. So the Adam's apple, like we had said in class, Common misconception is, well, that person's got an Adam's apple, must be a dude. Everybody's got an Adam's apple. It just does happen to be a bit more prominent in males than it is in females. Another area that you're going to probably hear quite a bit in the hospital during the potential or possibility of an endotracheal intubation is going to be that cricoid cartilage. Cricoid cartilage you'll see here sits directly below the thyroid cartilage, and there's a little space in between there. So if someone had to have like an emergency cricothyrotomy done, uh, then they would go through that cricothyroid ligament, and that's essentially where the airway would be placed at. So if someone gets a tracheostomy tube, they're likely entering in that area there. But another thing that you're going to hear with that little hard cartilage here, that cricoid cartilage, if you'll notice, if we're looking at the anterior view and the posterior view, that cricoid cartilage is a complete ring. Let me check something popped up in the chat box right quick. Let's see what's going on. Oh, it's all good. All good. Um, Cricoid cartilage is a complete ring. So you may hear during an endotracheal intubation, they may ask to give cricoid pressure, or they'll say, "Give me cric," for short. They may ask for cricoid pressure. The purpose. So the reason they're asking for that is you have to think about your anatomical terms, whether so if something is superior, that means it's above. If something's inferior, that means it's below. If it's anterior, that means it's in front of. If it's posterior, that means it's in back, behind or toward the back. So some individuals may present with a more anterior airway, meaning for whatever reason, their airway is more toward the front of their body than it is the back. So an individual might ask for cricoid pressure for the purposes of trying to move the airway more posteriorly, so it will drop that into view when you've got the laryngoscope down the patient's throat, so that you can hope to visualize that. That's why individuals will ask for it. However, that's not the intended purpose of that procedure. The intended purpose of that procedure, also referred to as the Selleck maneuver, uh, is to take that cricoid pressure and move it back, push it backwards. It is a complete ring. So ultimately, we talked about the reason why you have your tracheal rings that are incomplete. You'll notice those are incomplete, but that is a complete ring. These tracheal rings are these little things here that I'm talking about. Your esophagus sits behind there, so it would make it easier to swallow, or it would make it more difficult to swallow if those were complete rings. So with this being a complete ring, the true intended purpose of the Selleck maneuver, or the use of cricoid pressure, is to take that cricoid cartilage and press it uh, backwards so that it pinches off the esophagus, to hopefully help prevent from aspiration, or contents coming up from the esophagus during an endotracheal intubation. However, it has evolved uh, over the years to where individuals have opted to try to use that to move an anterior airway more posteriorly to bring it back into view. But if you ever see on your MBRC exam, an exam I might give you, the intended purpose for that cricoid pressure, or you may see it referred to as the Selleck maneuver, and that's Sellick, Selleck maneuver, uh, is to pinch off the esophagus to try to help prevent aspiration during endotracheal intubation. Uh, and then again, you've got the hyoid bone up there. The epiglottis is that structure that, or the flap of tissue that's going to cover the glottic opening to hopefully help prevent uh, things from foreign debris from entering the glottic opening. I think we may have gotten far enough along to talk about obstructive sleep apnea. So if I'm being repetitive, I apologize, but nonetheless, um, we'll uh, go over it again. This is again being recorded so that you can listen to it again if you like to. OSA, obstructive sleep apnea, these individuals tend to stop breathing at night when they go to sleep. There can be a few different things. This one specifically talking about obstructive sleep apnea. There are also things out there, and you'll get this more in your pathophysiology class, but there are essential sleep apneas as well, to where there's actually an issue with the brain that may cause an individual to stop breathing at night. But if we're talking about OSA, obstructive sleep apnea, that is going to be an occlusion of the airway when a patient goes to sleep, whether that's the soft tissues, what have you, that tend to just relax and basically closes off the airway when a patient goes to sleep at night. So you can see that very first bullet point talks about a decrease in pharyngeal muscle tone. So basically, when the tongue and all those muscles relax, everything just kind of falls backwards and can cause a patient to have snoring and things of that nature. These individuals will sleep all night, but yet continue to be sleepy throughout the day. And like I told you, when these individuals have their moments of apnea throughout the night, their sympathetic nervous system gets ramped up. Uh, every time that they stop breathing. So their fight or flight system kicks in. So for all intents and purposes, in that period of time, blood pressure goes up, heart rate goes up, sympathetic response is in full force. The release of norepinephrine occurs. So these individuals are tired throughout the day because although they slept, it wasn't a restful sleep because their body's sympathetic nervous system was activated all night because it was trying to prevent it from dying, preventing the body from dying while they were sleeping. So we definitely need to take sleep apnea was serious. There have been individuals that have passed away due to, I think I even mentioned a Green Bay Packer lineman that used to play, Reggie White. I think I've mentioned that in class. But he passed due to complications associated with obstructive sleep apnea. So they do have different treatments for sleep apnea. Obstructive sleep apnea, you can have a mouth guard placed. Uh, One of the more well, and that's not necessarily invasive. Uh, but you have another thing that individuals have done is like sew a tennis ball or something into the back of their shirt to prevent them from lying flat on their back, to keep them at least to the side or what have you. And then kind of where we're going to come in with the respiratory therapists is through the non-invasive ventilation adjunct. So we'll utilize continuous positive airway pressure. That's what CPAP stands for, continuous positive airway pressure. And typically that says 6 to 12 centimeters of water pressure, but it could be more, could be less. Depending upon the severity of the obstruction, and individuals find this out by going and having what's called a sleep study done. So they'll count the number of apneas that they have throughout the night, and that is where they have truly completely quit breathing. And then they'll also count the number of hypopneas that they have. Hypopneas are real shallow breaths that are taken, and then they'll come up with an apnea hypopnea index, which is basically take the two of those, divide them into one another, and it'll give them a score on that, and then that'll kind of help guide that. But when they go in for the sleep study, and so they may do like a split sleep study where they're actually measuring how many times, and then they'll do a titration study, or they'll have them come back. If they don't do it all in the same night, they can have them come back for another night. So the one night or the one night or the first half, depending upon however they decide to do it, they're monitoring how many times you quit breathing. And then the second time, they're actually applying positive pressure to the airway, and they're doing a titration study. And what they basically do is they'll go up on that CPAP level until they find the pressure that stents the airways open and prevents the individual from having obstructive events and what have you. Some of the machines that you all will see in the hospital will have like a VPAP auto, a variable PAP type setting where you set a high and a low, and it can titrate your continuous positive airway pressure up, or it can so if I set a minimum at 4 and a maximum at 16, then the pressure can go anywhere between those two to basically correct the obstruction. But that's not something that, like, for instance, if you're going to set someone up in the hospital on a CPAP, you need to have an order for a specified number, unless you're going to utilize one of those auto titrating type machines that I mentioned, because you do have to have an order if you're going to utilize a specific CPAP, and that order typically is going to come from their sleep study or the titration study that was done, so that you can stent their airway open. Because if you don't give enough pressure, they're going to still obstruct and have apneic events. And if you give too much pressure, there are thought processes that that could begin to induce central sleep apneas. And then we also have to be careful with excessive pressure going to the face anyway, because we wouldn't want to get gastric insufflation with that. Meaning we don't want to we want the air to go into the lungs, but if the air and or the pressure gets too high, that can actually go down the esophagus. And if a patient has a mask strapped to their face and you're blowing air in their stomach and then they vomit, there's a decent chance they may aspirate because that mask will be strapped to their face. So you want to be cautious of that. I did see a patient in the ICU one time, and if you have a BiPAP on someone, you're not supposed to restrain them, or at least those were the policies where I work. And at the time, they could be restrained if they were in ICU because an ICU had a dedicated nurse to where they were monitoring the patient. But I heard the BiPAP machine alarm, look over, and patient was restrained. So I had to hurry up and get over there and take the mask off because it would alarm, because the high pressure alarm went off because the guy threw up into his mask. And then when the machine fired, it sprayed all of it back into his face. So he probably cycled two breaths before I got over there to take it off of him. Then had to clean everything out, get a new mask. And then, he had to be followed up with to make sure that he didn't aspirate. So those are some things that we want to be careful with. Uh, so still talking about the uh, the anatomy of the larynx and so forth. We do have the vocal cords that you will find in there. They do open and close and they vibrate. That's how we make our sound. That they are essentially the opening to the actual trachea. That if you hear glottic opening or the glottis, that is the area in which they're talking about. It's going to be the opening and closing of those vocal cords, and it's going to be the area between those vocal cords that opens up to the trachea to allow air to go down in there. It does have the ability to open and close, just like we had talked about. So, taking a deep breath, they open up, you close, they tend to, or you cough, they tend to close quite a bit. And if you ever uh, were to watch either via bronchoscopy or laryngoscopy, where if you're looking through that and you have a patient speak, you can see those things move back and forth, or if they try to cough, you can see them actually actively close too. And there probably are some videos on YouTube that show that. If I can find the video, I uh I had my vocal cords inspected a couple of years ago. I'll have to see if I can find the video. But they did took a scope, run it down my nose, and then had me make all sorts of noises, and it was rather interesting to watch. So if I can find the video, I'll share that with you all at some point in the future. But I have to figure out what I did. I don't remember where I saved that file. Uh, so talking about the vocal cords, looking at those bottom couple of bullet points, we can develop croup and or stridor, and I think we talked about this the other day in class. You've got uh, this high pitched inspiratory sound that you're going to hear. So you could have croup, which is swelling of the vocal cords and of themselves. Different from that, you could have epiglottitis. So that structure we talked about that sits above the vocal cords, you have inflammation of that, and that's a life-threatening situation. You tend to want to get that patient to the ER. We could do racemic epinephrine for both cases, but if it's true epiglottitis, that individual is going to have needs to get an artificial airway placed before, because you're concerned with the airway swelling shut essentially. Uh, and we talked about the breath sounds that you would hear over the trachea, and that is stridor that you're going to hear. It comes along with croup and epiglottitis. You'll cover this in your pathophysiology course, but because we're talking about it, we'll go ahead and mention it. If you were to look at a lateral neck X-ray for a patient, uh, you're going if the patient has epiglottitis, you'll see something called the thumb sign. So if you're looking at uh, the lateral neck X-ray, it'll look like there's a thumb, uh, because the epiglottis, that the tissue is swollen, and it will look like a thumb just sitting in there, kind of doing the thumbs up deal right there in their throat or neck. If they were to have um, croup and so forth, then you can get into a situation where you might see a steeple sign, so a narrowing of the airways, so to speak. But again, you'll go over those, and they may also refer to that as a picket fence with a AP. AP being the anterior posterior film. If you haven't gone over chest x-rays already in pathophysiology, you should be going over them sometime soon where you talk about the differences in the anterior posterior film, the posterior anterior film, when you may do a lateral film, and so on and so on. But we'll let that be covered uh, by your patho teacher. Uh, Looking at the glottic opening. So if you do a laryngoscopy, this is essentially slide that bar out of the way. This is the view that you're going to get. You have the epiglottis here, vocal cords are here. That's the glottic opening there. You've got your arytenoid cartilages down at the bottom. Uh, so that this is the hole where you're going to aim for the vocal cords, and you would again through the vocal cords into the glottic opening, and typically you pass that in the tracheal tube just until the cuff passes through those vocal cords, or some endotracheal tubes have a little black line on them, and you can push that through until then. But I have found for the most part, if I push just until I get the cuff passed, I'm usually going to be in a pretty decent spot with that with that endotracheal tube. For the NBRC, and by the NBRC, when I say NBRC, that's the National Board for Respiratory Care. That's the entity that is writing the board exam that you all are going to take. You all will be the first class to take the new board exam, called the RTE. It's the Respiratory Therapist Examination, as opposed to where the senior cohort, that's the senior students that are here now, they will be our last cohort to take the TMC and the CSE, which is the therapist multiple choice exam and the clinical simulation exam. Uh, so, but I've looked at the detailed content outline for the exams that we're preparing, uh, the two exams, and I've also looked at the detailed content outline for the exam that we're now preparing you all for. And there's a significant bit of overlap. There's some new items and some things that have been omitted, but we're making those changes with the curriculum. I would imagine a lot of the questions stay similar in nature. So when if I mention something about the MBRC for MBRC purposes, I'm talking about the board exam that you're going to be taking when you graduate. So where I was going with that is the tip of the endotracheal tube. If you're looking at an X-ray, I'll see if I can pull one up real quick, just because we are should have the time to do it. Let me see if I can find an X-ray with an endotracheal tube. Let's see if this one. See if I can make that X-ray a little bit bigger. Okay, very good. So it probably you may have a little bit of trouble looking at it or what have you, but nonetheless, you can if you observe the X-ray. So when you look at a chest X-ray, you're going to have a couple of different color. You've got various different shades of gray or different shades of white that'll show up. So fluid, muscle, bone, other tissues will show up various shades of gray. Uh, Airfield spaces are going to show up radio lucent. So if something's radio opaque, it's a shade of gray, if you will. If something's radio lucent, it's super dark. So radio opaque is gray, radio lucent is dark, and airfield spaces tend to be radio lucent or show up darker. So, for instance, if you'll notice this black space around the body, well, that's just air sitting there that was absorbed. If you'll notice these black spaces inside of the lungs, you got air inside of the lungs. So that tends to make pretty good sense. You also have the heart that shows up here. You've got and keep in mind, if it's correctly oriented, this is going to be the patient's right side. This is the patient's left side. They'll usually put a little tag on the X-ray to let you know as well. So this is indeed the right side, and and it says portable. So we're looking at an AP film. Uh, so this is the right lung. This is the left lung. So this would be the left hemidiaphragm. This would be the right hemidiaphragm. The area where your ribs meet the diaphragm forms something called a costophrenic angle. That costophrenic angle should be nice and sharp. If you have some pathologies that cause your lungs to hold on to air and so forth, it can flatten out the hemidiaphragm and blunt that costophrenic angle. Uh, we'll talk about that moving forward as well. But what I wanted to point out specifically with this chest X-ray is if you look, you can see the trachea. Trachea, I'm following the trachea here with my cursor. And you can also find the carina. So right there where the index finger of that cursor is where the carina is. And that's the point of bifurcation where the trachea splits into your right main stem bronchus and your left main stem bronchus. So here's your right main stem bronchus going to the right lung. Here's the left main stem bronchus going to the left lung. So when you place an endotracheal tube, all endotracheal tubes have what's called a radiopaque line on it. That radiopaque line, so radiopaque, I told you it shows up white or a shade of gray. That radiopaque line will be exactly that. So if you'll look, this white line that shows up right here is that radiopaque line on the endotracheal tube that I had mentioned to you. This, where it terminates, basically indicates where the tip of that endotracheal tube is. So this terminates here. There is some distance between the tip of that endotracheal tube and the tip of the carina or where the carina is at. By MBRC purposes for your exam, that space should be 3 to 5 centimeters. So the tip of the endotracheal tube should be 3 to 5 centimeters above the level of the carina. Uh, in the hospital, you may hear individuals say 2 to 4, so it won't be uncommon for you to hear that in the hospital. But for the purposes of the board exam you're preparing for, 3 to 5 is the range that you're going to be looking for on that. So it's 3 to 5 centimeters above the level of the carina where the tip of that endotracheal tube should be found. And it showed this says endotracheal tube within the right main bronchus. So just while we're looking at it, I'll pull it down and then we'll get back to it. Oh yeah, you can see how that tube is migrated into the right main stem bronchus. So if you follow that uh, radiopaque line, it terminates here. You can see that the carina is right there. So that the tip of that tube is in the right main stem bronchus. We mentioned the right main stem bronchus intubation the other day in class. So we can see a couple other things that we can see going on with well, not quite as. It'd be nice if there's a little bit better resolution, but you can see some lead wires, and we also see that this patient has a pulmonary artery catheter in. So if you see this line right here coming in through the right part of their neck, this enters. Remember, we talked about blood flow through the heart. So if you put in a pulmonary artery catheter, the purpose of that catheter is get into the pulmonary artery so we can read what's called a pulmonary capillary wedge pressure off of that. So we enter through the right atrium, into the right ventricle. Through the right ventricle, we go up into the pulmonary artery, and then that catheter is going to rest in the pulmonary artery, and it's got a balloon on the end of it that you can wedge it and get your pulmonary capillary wedge pressure. That stuff will make more sense as we progress more into the hemodynamics of the class, but you all are getting into clinical, so you should be looking at chest X-rays. You should be learning about chest X-rays in school, and chest X-rays are going to be one of those things that the more you look at them, the better you're going to get, and the easier things will stick out to an extent. Uh, so hopefully you can remember radiopaque line on the endotracheal tube, and the tip of that endotracheal tube should be 3 to 5 centimeters above the level of the carina. So we'll go back to the presentation now, and we'll keep trucking. Uh, with that, did mention the dichotomy of the lower airways. We did get this far because I went and grabbed that anatomical figure and kind of showed it to you. So we do look at the trachea, left and right main stem bronchus as being a tree. If you can imagine a tree being upside down with all these little bronchioles or terminal bronchioles that lead down to the alveoli, and the alveoli is going to be where you have the actual site of gas exchange. So, like I said, the airways just provide the path for air to get to the alveoli. But the gas exchange actually occurs at the alveolar capillary membrane when that occurs. So the trachea, you should be able to palpate your trachea. Typically, you take two fingers and make sure that that trachea is midline. So, for instance, there are some disease processes that can cause that trachea to shift. You've got diseases that will push the trachea and the mediastinum away from the affected side, or you have disease processes that will pull that trachea to the affected side. Those are things that you should cover in pathophysiology. But if you think about it intuitively, it should make sense. If you were to have a tumor or something in the chest, it would make sense that that tumor would exert a pressure and push the trachea away from it. If you were to have a pneumothorax, it would make sense that that pressure pushes the trachea and or the mediastinum away from it. So anything like that, whether it's fluid buildup, fluid accumulation, air accumulation, tumors, masses, whatever, those types of diseases are going to push the trachea away from the affected side, as opposed to where atelectasis, pneumonia, consolidation, things along those lines, where those alveoli begin to close down, they consolidate down, they're going to pull the trachea to the affected side. So that's going to be some verbiage you want to pay attention to when you're taking a test, because you will come across an MBRC exam item where they're giving you details from your inspection, palpation, percussion, and auscultation as you're taking care of those individuals. And it may discuss breath sounds, whether they're diminished, absent, or what have you. And it'll also tell you you have tracheal deviation, and that tracheal, you'll have to pay attention to the direction of the tracheal deviation, because sometimes they'll ask you to provide the therapeutic intervention or what have you as you're going there. So those are definitely things that we'll want to make sure that we are attentive to as we continue to progress and get you guys ready for that RTE exam that you're going to take post graduation. Um, So, how long is the trachea on average in the adult patient? Somewhere between 10 and 11 centimeters, so to speak. And it does go extend down to C6 to T5. And we're looking at the angle of Louis. We talked about this the other day. So, if you're trying to find the angle of Louis, if you come up here and find this little notch right here in your chest. So this little V that you might find, so that's your suprasternal notch. If you come down over that, you're going to have that outward protrusion. You're over the manubrium at that point. Then you have where the manubrium meets the sternal body. There's an outward protrusion that puts you directly over rib two. That connection there is the angle of Louis that we're talking about. So if you slide out over beside the angle of Louis, that you're directly over rib two. So the rib above that's rib one. That's going to be important for being able to find your intercostal spaces. So between rib one and rib two is your first intercostal space. Then you can kind of stay close to the sternum and you can count down or walk your fingers down the chest at that point so that you can find those intercostal spaces. Because once we get to the summer and you're doing EKG, electrode placement on individuals, you are going to have to be able to identify the fourth intercostal space, the fifth intercostal space, and line some of that stuff up with anatomical locations such as the midclavicular line, the anterior axillary line, mid axillary line, and so forth and so forth. We already talked about the carina. The carina is where you uh, the trachea bifurcates into the left and right mainstem bronchus. The angle is a little more steep to the right than it is to the left. So if you aspirate, likely it's going into the right mainstem bronchus. If you slip an endotracheal tube in too deep, you're likely to go into the right mainstem bronchus more so than you would the left. It doesn't mean that you can't get into the left mainstem, but you're more likely to go right mainstem. We also have something called the isothermic saturation boundary. We talked about this. So at this point, you have we said that the mouth and nose, and the nose specifically, helps to warm and humidify the inspired air that we're breathing. So the nose helps to warm the air and add some humidification to it. And once we get that air down to the level of around where the carina is, at that point, out the air within our lungs should be 100% saturated relative humidity at body temperature, which is 37 degrees Celsius. We had talked about if you were to breathe in a drier gas source, or if you place it in a tracheal tube and you bypass the nose, you can, and if you're not adding any type of humidity to that air, you can shift that isothermic saturation boundary more distally into the lungs, and then that can cause thicker secretions. Your nose and stuff may begin to run at that point because your body's trying to actively add moisture to the air that you're breathing in. So that's going to be important thing to remember. And also remember the amount of water that can be that's held at that point as well. And that should be 44 milligrams. So if, for instance, uh, if you were to be 50% saturated at that point, you just cut that number in half. It would be 22 at that point instead of 44. And that was covered in the reading. So we want to make sure that we can remember that moving forward. Uh, if you look at the cross section of the trachea here, you can see, uh, you know, ultimately you've got the different types of epithelia there. This is going to be important as we get to talking about the mucociliary escalator that occurs. You do have some ciliated mucosal lining that helps move any type of foreign debris back up to the main airway so that we can cough and hopefully expectorate that and get it out. But this is just a continuation of the things that we have talked about already. And do remember that area where your airways and vessels enter the lung. That's going to be called the hilum or the hilar region. So some of the numbers we were mentioning just a little bit ago, we're looking at with the isothermic saturation boundary, you're at 37 degrees Celsius, 100% relative humidity, and the water content is 44 milligrams per liter at that point. Those are some numbers you're going to want to remember. 37 degrees Celsius, normal body temperature, 100% relative humidity at that point at the isothermic saturation boundary, all at the level of the carina, and that it holds 44 milligrams per liter of water if we're 100% saturated relative humidity at body temperature. Uh, because I have looked ahead at the exam and I know I told you all that you all are going to have math in this class, but there's not a significant volume of math on exam one. Uh, the Actually, I think out of all 50 questions that I looked through and read, I believe there's one that has math, and that math you should not need a calculator to do as long as in your, if you can do math in your head, as long as you can cut a number in half or cut a number in fourths, you should be able to answer that one question that includes math on the test. Now, that being said, that's where you've got to actually compute something. There may be some questions that concern math, but it's just basically recall questions where you're remembering components of a formula or something of that nature. But there's not a significant volume of mathematics on this first exam that we're going to take here in just a couple weeks in this class. So if you look at the concept question that's here, it says foreign material aspirated into the trachea is more likely to enter which main bronchus? Hopefully that's pretty self-explanatory. You're a lot more likely to go, but based upon the anatomy, into the right main stem. Did talk about our conducting airway. Conducting airways are just simply the airways that are getting the air that we breathe in all the way down to the area of the alveoli. You do want to make sure that you pay attention to in your book. I've got an older edition than you all have, so if I give you a page number, it probably won't line up exactly right with the page number that you all have. But you all should have a chart in your book or a diagram or illustration that looks similar to that. Um, those are the segments of the lung. So you want to make sure that you go by and can know those segments of the lung because you may have some questions that pertain to what the segments of the lung are and what have you. And those are also going to be important because you all will have some questions in your 111 class on postural drainage and chest physiotherapy. So knowing those segments will allow you to be able to apply that knowledge to what branch or division of or what segment of the lung you're trying to allow gravity to help facilitate uh, with removing secretions from there. So when you have dichotomy of those airways, it just means they continue to branch and split all the way till you get to your alveoli are those terminal bronchioles that are going to allow us to get down to the alveoli where gas exchange is going to take place. So what I just held up, uh, you have it here in the PowerPoint. So I would go through and review and make sure that you can understand and know where those different segments are, or whether you need to do flashcards or however you study best. Those are the segments that you need to know. Pointing at my screen like you can see where I'm pointing. Sorry about that. This area here where we talk about the blood vessels and the actual airways entering the lungs, that's going to be considered your hilar region or the hilum. And it just gives you a breakdown of the different views that you would have of the heart. And we've got a couple of models that are made up just like this in the so where you all keep the your food in the refrigerator. If you look on the shelves and stuff, there's a couple of models that look just like this. If you wanted to be able to get something out tangible while you're going through and studying in class or an open lab, you're welcome to do that as well. We did mention the other day, briefly, we talked about dead space and shunt. Dead space is ventilation without perfusion. Shunt is perfusion without ventilation. So let me see if I can draw on the screen just a little bit, and I'll try to hopefully help that concept make sense. So let me tone that down just a bit. So when we talk about an alveolus, and you'll have to excuse me, my drawing is not. Let me got a got a pad that maybe I can do a little bit better with. Let me get it plugged in and see if I can draw just a little bit better with this pad. Uh, so you've got an alveolar unit, and with that alveolar unit, you have blood flow that goes past it. I'll change colors right quick. I'll go green for O2. So we know that when we breathe in O2 to the alveolus, and that oxygen should go into the bloodstream, and we'll do uh, CO2. CO2 should come out of the bloodstream, so it should go into the alveolus. CO2 should go into the alveolus, while oxygen should go into the bloodstream. And that's under normal conditions what should happen. So an instance where we have dead space. So if you have dead space is ventilation without perfusion. Dead space is ventilation without perfusion. So if for whatever reason, maybe it's a pulmonary embolism or something of that nature, and do keep in mind that we'll just say blood flow is moving in this direction. So if I have some type of occlusion to blood flow for whatever reason, and there is no blood flow going past here, but yet this alveolar unit continues to be ventilated in that you have air going in and out of that alveolus, but no gas exchange taking place. Ventilation without perfusion. Perfusion is blood flow. Perfusion is blood flow. So ventilation without perfusion is dead space. So if you have a dead space is ventilation without perfusion. So anytime there's air moving through an airway or getting down the alveolus, but there's no perfusion that occurs, that is dead space, ventilation without perfusion. So now we may have a situation where we have an alveolus. We'll continue to have blood flow. So now, for whatever reason, we've got blood flow moving this direction just like it should. But now let's say I have a situation where I have, so if you've heard about ARDS or something of that nature, maybe there's now fluid or maybe there's pulmonary edema. There is now something that fills that alveolus and it prevents the air that would be in the alveolus so at this point you may have O2 here, but it not actually get down to the alveolus that's making the gas. So you're going to have blood that goes past here. So deoxygenated blood that's supposed to be oxygenated by going past that, but it doesn't. So deoxygenated blood stays deoxygenated and it continues on its route. So this is perfusion without ventilation. So there is no ventilation getting, so there's no air that gets to that alveolus because of it being full of fluid or whatever. So there's no gas exchange that takes place in this regard. In both situations, there's really no gas exchange that takes. You've got this is wasted ventilation over here. Uh, Dead space ventilation without perfusion, and then you have shunt. So this would be shunt over here, where you have perfusion but no ventilation. So perfusion but no ventil. And I'll just put vent because I'm running out of space. Over here you have dead space, and that is ventilation without perfusion. So this is perfusion without ventilation. These are two concepts that are going to be important for you to remember moving forward. You don't necessarily have to master them per se for our upcoming exam, but it is something that you want to go ahead and begin to try to wrap your mind around. Because this general concept question here, or concept question that we have says, what general effect does an endotracheal tube have on the volume of anatomical dead space? So when we talk about dead space in of itself, we said that dead space is ventilation without perfusion. So let me clear those drawings right quick. Clear it all. So now, if I were to take and have, I suck at drawings, but you have to bear with me. So now, if I've got a patient and we know that their chest is here and their lungs here, all right, that's terrible, but you get the main gist of what's going on. So when this patient breathes in, they've got a nose, they've got a mouth. Yeah, right there. Put some eyes on them so they look halfway normal. When they breathe the air that's out here in, some of that. So if they take a 500 cc tidal volume, so when they breathe in, if they've got a 500 cc or 500 milliliter tidal volume when they breathe in, I've just pulled in 500 cc's of air. Well, the trachea, the nose is going to hold some of that 500. The mouth and the nasopharynx and the oropharynx is going to hold some of that 500. The trachea is going to hold some of that 500. The right mainstem bronchus will hold some of that 500. The left mainstem bronchus will hold some of that 500. And all those bunch of little tiny airways that go all the way down to the alveoli will hold some of that 500 cc's of tidal volume. So what I want to impress upon you here is when you take in a breath of 500 cc's or 500 milliliters of volume, not all of that makes it to the alveoli. So you will have um, just a small. So of that, I just for grins and giggles, we'll say 100 cc's of that actually makes it to the alveoli. So if you have 100 cc's of that, that means out of that one breath, 400 cc's of that was dead space ventilation. Some of that's when you look at the anatomic dead space, what have you, that's going to be the mouth nose. When it's asking, reason I go through that is just so you hopefully have a better appreciation of what dead space ventilation is. And when this says endotracheal intubation, what does it do to the volume of anatomical dead space? Well, if an endotracheal tube is going to bypass the oropharynx and the nasopharynx, so it really should decrease the overall amount of anatomical dead space that occurs. And if you guys can remember anatomical dead space, many uh, resources may go ahead and say that anatomical dead space is estimated to be 150 milliliters or 150 cc's. But you remember we said you can also kind of predict 1 pound or 1 milliliter per pound of body weight for an individual will kind of be indicative of what their dead space is too. And dead space is ventilation without perfusion. Uh, Any questions about that? I know I've been talking pretty quick. Do you guys have anything? If you want to unmute, you can. If you want to put it in the not the microwave, in the chat box, you can. And if I don't see anything in there next little bit, we'll just keep going. All right. Keep keep rolling. Terminal bronchioles, that is where we're getting down to the acinus. That's going to be the area where it involves or includes the alveoli. So this is going to be the space where gas exchange occurs. There's not any cartilage down there, so we are dependent upon muscle tone. So uh, remember, your larger airways are supported with have cartilaginous support. The smaller airways, you're dependent more along muscle tone. So that's where your sympathetic and parasympathetic balance is going to come into play where we talk about that bronchospasm that can occur. And if you give a beta 2 agonist such as albuterol, it's going to have its impact there to help maintain that out that bronchus from because it helps relax that smooth muscle and gives you a nice diameter to breathe through. When we talk about airway resistance, I think we may have gotten this far too. So if I've rehashed a bunch of this, I'm sorry. But when you talk about the huge cross-sectional area under that third bullet point there, it's like I told you, if you take one coffee stir and try to breathe through it, you're going to find that you've got to exert significant energy to do it because there's going to be quite a bit of airway resistance. But if you take like 100 coffee stirs, put those in your mouth, you're going to find that you breathe quite a bit easier because now you are spreading that airway resistance over a significantly larger volume of smaller. So when it says you've got upper airway resistance being greater than lower airway resistance, I want you to keep in mind that if you were talking about a single airway, so if I were talking about a single airway, so I utilized if you take a regular drinking straw versus a coffee stir, if you take one airway, one large airway and one smaller airway, and you're just comparing the two airways, yes, that smaller airway is going to have significantly more airway resistance. But the reason this says that the smaller airways have less airway resistance than the upper airways is because there's so many of those lower airway resistance. So it's the same thing where we're talking about taking 100 or 150 of those coffee stirring straws, putting them out. It's being spread across multiple, and so significantly there's less airways. But if you were to take them individually, one real small airway versus one large airway, then yes, that small airway is going to have a lot more airway resistance than the larger airway. But because the smaller airways are so abundant in number, there's typically less airway resistance when we look at that. So, concept question here. If you can remember that analogy with the coffee stirs, that's the answer to this because it's spread over the course of several different airways. So it says, why must many small airways be obstructed before measured airway resistance is abnormal or the person affected feels short of breath? And it's got to be many of them because you have so many smaller airways. So your airway resistance is relatively smaller. So it would have to take a fair amount of those to be occluded or obstructed before you begin to feel that shortness of breath. Uh, so when you start to look at kind of what we've talked about here, when we talk about the greatest resistance to airflow, the least resistance to airflow, if you tend to think about that, uh, ultimately, the wider the diameter, the less resistance to flow that it should apply. But keep in mind, you've got a bunch of those little airways stacked on each other to where it tends to reduce that. But if you're talking about individually, say the trachea being the biggest airway we've got versus terminal bronchial, and you're looking at them individually, there's going to be significantly more resistance in that smaller airway than there is the larger airway, just because of the inner diameter. But when you multiply those smaller airways by thousands, um, and you got air kind of being dispersed throughout that, then yeah, there is less resistance altogether in the lower airways than we have the larger airways. Uh, so the acinus, you've got your terminal bronchial, what's up, Faith?
Yeah, so I just need I need you to go through that. I know you did it twice, but I need you to go through that comparison one more time on the airway resistance between the upper airway and lower airway.
Okay.
So I'm trying to see if I'm getting this. Upper airway resistance occurs because of its diameter, that is
So
more.
airway resistance in general occurs because of diameter. So if I'm going to try to draw on the screen a little bit, let me pull this tab back up. I know my artwork is not fantastic, but no. So ultimately, if you're looking at the diameter of um, so if you think back to, and you may not have gotten to it in 111 yet, but you have something called Poissier's law, where
Yes,
it
that
talks about
airflow.
yep, we talked about airflow. The length and the radius of a tube is going to have a direct impact on its airway resistance. So for instance, if I have a large airway, such as the trachea, versus a terminal airway, a terminal bronchial, which is going to be like if I'm looking at those, so this is I put a trachea for here and a TB, not for tuberculosis, but for terminal bronchial here. Then I'm going to have significantly less resistance moving air through this large airway than I would this super small airway. This is going to be more resistant. But because these terminal bronchioles are abundant in number, then that's how the book and how in general we can get away with saying there's actually less resistance among the smaller airways just because there's so many more of them, so it gets spread out throughout those. Does that illustration help any at all, Faith?
Yes, it does.
Very cool. So are we good, or I know you need more?
Nope, that'll do it. I need that illustration.
All right, sounds good. All right. So the acids gets down to the actual uh, alveolar air where gas exchange is going to take place. You've got these pores of Kohn um, and other channels that basically connect alveoli to alveoli and airway to airway. So you can see those there. So ultimately, when you one of the probably, I don't know, my kids in the past, and I don't have one here, but the dollar store, Dollar Tree or whatever used to sell these little like uh relief balls, if you will, that have like a net on them and you squeeze it, a bunch of little bubbles pop out over it or what have you. But it puts me in the mindset of an alveolar unit when you squeeze those. And I could basically mimic like pressure control ventilation, volume control ventilation, or even high frequency oscillation ventilation. I'll try to find that toy and bring it to school with me, or bring it to class with me when I can. But nonetheless, millions of alveoli. Uh, those are the air sacs. So this is the effective component of the ventilation. This is the only place where alveolar ventilation is the only effective ventilation we have because this is so when you breathe, we talked about dead space. Air that stays right here in this airway, that's dead space. Air that stays in this airway is dead space. Air that stays in that airway is dead space. Air that gets down here to the alveoli, that's functional air. It participates in gas exchange, so that's no longer dead space ventilation. But air that stays in these airways that does not participate in gas exchange is all dead space ventilation. So we talked about, and I think maybe we did, maybe we didn't get this far talk about, but I know I recorded a lecture and I sent that out too. So maybe that's part of what I'm talking about that I covered. But we do have our pseudostratified columnar epithelium within the airway in of itself. That contains that uh, mucociliary escalator that we had mentioned. So you've got a gel layer and a sol layer. Um, that gel layer basically is going to serve as like a sticky film, if you will, or almost like fly paper that catches foreign debris that we breathe in. And then the sol layer is a real liquid type, instead of doing hand motions, let me just get to the illustration where it's at. So this is much better than anything that I can draw. Uh, you do have your gel layer, you've got your saw layer. These little lines here are going to be your cilia that are going to beat back and forth. So ultimately, if you look at that overall mucosal blanket or mucus blanket that we have here, you've got different types of cells in there, whether it's your goblet cells, Clara cells, things that are going to help produce and secrete these secretions. You've got these tiny cilia on these pseudostratified ciliated columnar epithelium that line the airway. You have that gel layer and the saw layer that says so that gel layer is gonna, like we said, be real, have a sticky consistency to it so that if we breathe in anything foreign, it can get stuck to that gel layer. And then the saw layer uh, has those little hairs that beat back and forth that are going to help move everything back to the main airway so that when you take a deep breath, you can cough out what it is that you had potentially breathed into your lungs. Uh, Cigarette smoking stuns that ciliary activity. So individuals have a more difficult time clearing their airway. And you've probably heard of that real thick, nasty, congested smoker's cough. Reason being is because they have damaged their mucociliary escalator system and their body's not as effective or efficient as at getting rid of those secretions or what have you that we have. So we do have the different types of respiratory epithelium, if you will. That pseudostratified columnar epithelium is going to be a big significant role within the mucociliary escalator. You've also got the goblet cells we talked about that can produce mucus, and then the adventitia. Always think of adventitia as kind of like a saran wrap or whatever, if you will. It's kind of a tissue that kind of holds stuff together. Uh, So inherently, our body's going to put out somewhere in the ballpark of 100 milliliters of mucus a day. Now that can be ramped up based upon disease processes. So CB is chronic bronchitis, CF is cystic fibrosis, asthma is asthma, and you're going to have an increase in mucus production with any of those disease processes that are listed there: chronic bronchitis, cystic fibrosis, and asthma. Are those only three items that are going to cause you to have an increase in mucus production? No, that's just examples that are provided there. But pretty much anything that irritates the respiratory system can cause an increase in mucus production. But on average, normal healthy adult creates about 100 milliliters of mucus per day. So you probably swallow a bunch of that. You may spit some of it out, what have you, but you probably do swallow a good bit of that. We did talk about the mucosal blanket and how those cilia help direct everything. So we do want to not be terribly redundant and repetitive of that, um, but just understand those two different layers, your gel and your saw layer. And we also look at the what can impair that mucociliary clearance. I did mention cigarette smoke. If you live in an area that has a lot of air pollution, that can do it as well. And dehydration. So if you think about it, when you go to the doctor and if you happen to be sick or whatever, and they're telling you you need to make sure you get plenty of rest and drink plenty of fluids, uh, those fluids are going to help for the hydration of your respiratory system, helping keep an all that. That's why it's important to drink to stay well hydrated if you're sick, because not only does it improve the other organs, but it is going to significantly help improve the overall function of the lungs so that that mucociliary clearance system can work appropriately and hopefully help your body be able to rid itself of the things that might be making it sick. Um, Humidity, we've talked about that. We've got to maintain an appropriate, we need everything to be 100% relative humidity, body temperature as we're breathing in. That's why we need to make sure we're breathing in through it. Actually, if you plugged your nose and just breathed in and out through your mouth, your body would not be able to effectively warm and humidify the gas that you're breathing in. So you would probably have some physiologic effects, negative effects that would occur. So it's very important to be able to breathe in and out through your nose. So if we were to ever bypass that um, with an endotracheal tube or a tracheostomy tube, super important to add some type of humidification device, whether that's an HME or an artificial heat and moisture exchanger or an artificial nose to that, or if you're providing either if it's passover humidification or active humidification, and you'll learn about that in 111 as you continue to move forward. Remember that isothermic saturation boundary is at about the level of the carina, and drier gas does move that distally. So that means it moves that isothermic saturation boundary lower into the chest, and it shows up again here. But that second bullet, remember 37 degrees Celsius for body temperature, 100% relative humidity, and we're holding 44 milligrams of water per liter uh, at that temperature. So that's something that you want to make sure that you can remember moving forward. And then anything that causes if you have a humidity deficit, then that's going to cause the mucociliary clearance, the mucociliary function to be reduced. It's not going to be as effective. So now we talk about other cells that we're going to find in the lung. So when it says non-epithelial cells, these are cells that are not part of like the lung structure, but they show up as well. So some of these should be you should recall these from pharmacology because they were gone over, I think, in chapter 7 in pharmacology. So if you look at the eosinophils or eosinophils, remember your immunoglobulin E, those are going to show up in response to allergens or an allergy situation. Neutrophils, when you look at, uh, if you look at a white blood cell count, so if you get a CBC and you look at the white blood cell count, there's going to be a differential of that. You're going to have your leukocytes, neutrophils, lymphocytes, eosinophils, and monocytes. So you have those different components of the white blood cell count. Eosinophils and neutrophils are a component of those. Eosinophils are going to be elevated in response to allergic type reactions. Neutrophils are going to be elevated in response to bacterial type infections. So those are going to be if you got an increase in neutrophils, when you look at a CBC or a white blood cell count differential, and they're looking at whether or not they're gonna call it a virus or a bacteria. The elevations in that differential is going to let you know if it's viral or bacteria. If the neutrophils are high, it's probably more along the lines of bacterial in nature, and then an antibiotic might be an appropriate course of action there. But if the neutrophils aren't elevated and you've got something like an increase in lymphocytes, then maybe it's more viral in nature, and you're probably wasting some medication and potentially leading to multi-resistant drug organisms if you were to treat somebody with an antibiotic in that regard. So we want to make sure we're attentive to that. You all probably remember going over mast cell degranulation when you talked about the immune and inflammatory response. When we get there, so the mast cells, those are in the lungs as well. They are on those epithelial surfaces of the airways. If they break, they release histamine and they degranulate, and they trigger an inflammatory response, which is going to cause more mucus production, more bronchospasm, more inflammation. So you're going to get all three mechanisms of bronchoconstriction occurring uh, in that regard. Remember, those three mechanisms were bronchospasm, secretions, and inflammation. Uh, we also have the epithelial chloride channel. So we've got remember, water is going to follow salt, so to speak. So we do have these chloride channels and sodium channels that are going to help with water coming into that and coming into the airway and helping to maintain uh, the moisture and the hydration of that mucus, and helping to also facilitate your ciliary function. When you if you've ever heard of a sweat chloride test, they do that testing for individuals that they're trying to determine might have cystic fibrosis. So we want to keep that in mind. So if they do a sweat chloride test, that's typically where they put an electrode on the skin, wrap it up, and then they collect the sweat and uh, read it for the amounts of chloride. So individuals are going to have higher amounts of that if they happen to have cystic fibrosis. Uh, we also have, so these items are there to help protect the lungs, but they can trigger inflammatory. So inflammation by our body trying to protect itself, it in some ways can harm it if it makes it more difficult for you to breathe in the process. So you do have anti-proteases and so forth. Those are basically inhibitors of proteolytic enzymes. You've probably heard of like alpha 1 antitrypsin and so forth. These are items that hopefully help uh, uh, protect the lung structure in of itself, but we can have you see here in that second bullet point, chronic inflammation, whether it's cystic fibrosis, COPD, asthma, individuals that have cigarette smoke, that's going to constantly trigger these inflammatory responses, and that's essentially going to cause long-term, if not permanent, damage to the overall lung parenchyma of itself. Um And our neutrophils, we do want our neutrophils to help break down and take care of any type of bacteria there, but you're also going to have byproducts of stuff. So the neutrophils are going to release something called elastase. Well, that elastase in of itself can have an impact on the elastin and the collagen, which can have a detrimental impact on the overall functionality of the lungs later on in life. Down to, I think we're getting close to the end of this chapter, and then we can move to the next one, but I'll give you about a 10 or 15 minute break before we start the next chapter, just because I know it's been a mile a minute since we started. Um, but we're down to the alveoli and capillaries. So this is a microscopic view of what those alveoli look like. Um, if I can't find it today, because I don't know if I brought my flash drive home, it may be in my office at work. But I have on there a microscopic view of alveoli under what's called conventional ventilation and then high frequency oscillation ventilation. It's pretty interesting to see. So if I can pull that video up, I'll try to show you that as well. But it's estimated you've got roughly 300 million alveoli in the adult lung. Uh, and those, so when you're born with the alveoli, but your lungs continue to grow and mature all the way up to like 8 or 9 years old. So they'll continue to multiply their alveoli and so forth. So we do look at the overall gas exchange area that we have, and that says 50 to 100 square meters of gas exchange area. So I think your book alluded to that being like what, half a tennis court. So that's a significant volume of area in the lungs to think about that you would have with that. And we do have our pulmonary capillaries that are going to surround those alveoli so that gas exchange can take place. You've got the arterial side of the capillary and the venous side of the capillary. And remember, in pulmonary circulation, the arteries are carrying deoxygenated blood through the pulmonary circuit into those capillaries where gas exchange takes place. They drop off the CO2, pick up the oxygen, and then through those venules and veins, the pulmonary veins are going to carry that oxygenated blood back to the heart so that it can be back to the left heart so that it can circulate it out to the rest of the body and so forth. And that is where gas exchange takes place. That's the only effective ventilation that you're going to have, and that is alveolar ventilation. And there's some more views of how it might look. You can see the capillary network surrounding those alveoli there. It's quite interesting enough, depending upon when you get to pathology, it might be in your patho book. You can actually see some pictures where some of these things may rupture. And then obviously that brings about different types of disease process and so forth. But pretty cool to look at nonetheless. There's a illustration of it. Like we said, you've got your pulmonary artery carrying the deoxygenated blood. Pulmonary vein is going to carry the oxygenated blood back to the heart. So this is coming from the right heart, going back to the left heart from the alveoli. With the alveolar capillary membrane, so you've got type 1 pneumocytes, you have type 2 pneumocytes. Type 1 pneumocyte is your respiratory epithelium. Type 2 pneumocytes actually produces your surfactant, your pulmonary surfactant. Remember, the role of pulmonary surfactant is to reduce surface tension to make it easier for that alveolus to open. So if you remember Laplace's law, as the radius of a sphere decreases, its surface tension increases. So if you've got an alveolus that's closed down, surface tension is greatest, that surfactant coats the inside of that alveolus. And the role of surfactant is to reduce surface tension to make it easier to inflate that alveolar unit once once you take that breath. And then as that alveolus gets bigger, the surfactant's going to thin on the inside of that wall, and then surface tension gets bigger, and you've got elastic recoil forces that facilitate exhalation. And we're going to talk about that in more detail when we get to chapter 3, when we go over the mechanics of ventilation. Uh, so we do have a blood and air barrier or a liquid air barrier, liquid air interface. With alveolar capillary membrane, it does allow for the transport of gases back and forth across that. So you can see CO2 comes out, O2 goes in, uh, and it is super permeable. And anytime that you have a disease process that thickens that alveolar capillary membrane, it's going to decrease the ability of the body to exchange those gases. So we talked about those already, the difference between your type 1 and type 2. There is a type 3 pneumocyte as well. Those are going to be referred to as your alveolar macrophages, and those are just going to help kind of perform phagocytosis, eat and engulf and get rid of anything that's bad within the lungs that isn't supposed to be there. So the type 2 pneumocyte produces pulmonary surfactant, and once it's produced, it stores those in those lamellar bodies, and then the lamellar bodies will release the or secrete that surfactant kind of as needed. And that's it for the chapter one. If you guys have any questions on that, feel free to put them in the chat box, Remy. You might, but what I'm going to let you do is because I've been talking, I'm going to start a timer and I'll give you 10 minutes, and then we'll get back at it in 10 minutes with the second chapter, and we should be able to wrap that up today. So you all take a break. If you got something to ask, put it in the chat box, and I'll be back shortly to answer those. All right, it's been 10 minutes. We'll go ahead and get started back. We're going to do chapter two. Hopefully, we'll get this one done. That way, we can stay on track and finish or begin chapter three, the next class period that we're together. Because I think chapter three is listed for two dates. Hopefully, it won't take a full two days to get chapter three done. Then we can reserve some of that time on the second day for chapter three, to review concepts and stuff for the upcoming exam, because that'll be just in a few weeks. But nonetheless, we'll go ahead. I don't see anything in the chat box, so we'll go ahead and get started with chapter two. The objectives are listed there. I'm not going to read through those, but let you guys take a peek at those. Some of this uh, should be review from pharmacology when we talk about the sympathetic and parasympathetic, whether or not you're utilizing uh, adrenergic, non-adrenergic, or cholinergic, non-cholinergic agents and so forth. So we can do that. So we looked at the heart. We talked about the apex and the base of the heart, with the apex, apex being able to be felt in that mid-clavicular fifth intercostal space, and while the base of the heart kind of sits a little bit more base. When we're looking at the apex and the base of the lungs, the apex is the top part of the lungs, while the base is going to be the lower part of the lungs. So if you are listening to the apex of the lungs, a lot of times, if you can fit your stethoscope into that groove where the clavicle is, that's where you could listen to the apex of the lungs at. Uh, or you can still listen to the top parts right around the clavicle if you're listening to the anterior chest, and in between the scapula if you're listening to the back of the chest. You may ask a patient to kind of hug themselves to move those scapula out of the way so that you can listen posterior to the apex. If you'll remember going over your inspection, palpation, percussion, auscultation, when you listen to the lungs, I would venture to say that most of the time when you go into the hospital and you see somebody ask them to take a deep breath and listen, they're going to listen apex down. And, you should compare each side. So if I listen to the left apex, then I should listen to the right apex and come down. And like I said, compare each similar anatomical region as I'm going through and listening to those breath sounds. If you can remember, the Egan textbook had mentioned that you should always listen beginning with the bases and moving toward the apex. And the rationale or the reason behind that was because you ask them to take a few deep breaths. If you start up here, you may miss some atelectasis or consolidation that was in the bases. Uh, but I guess a counter argument to that would be, if two deep breaths or three deep breaths corrected that atelectasis, was it truly if the patient yawned or they took a deep breath, that was going to be kind of uh, it would kind of fix. But that's why your book stated to start from the base and work your way up. But you're likely going to see in the hospital a lot of individuals will listen from the apex and work their way down. So I just kind of talk about that for a moment. We do have our costal surfaces. So when we talk about the root word cost in of itself, that's in reference to the rib. So if you're looking at intercostal spaces, that's the spaces in between the ribs. The costophrenic angle is going to be where the ribs meet the diaphragm, and I talked about that when we looked at a chest X-ray a little bit ago. When you look at the mediastinum, so housed in the mediastinum, you do have the heart, the aorta, your great vessels or great veins of the heart, the trachea, main stem. So everything within that mediastinum is covered, and your chest is the rib cage that's going to protect a lot of those vital organs that we have, and it even extends down the back to. So the rib cage in of itself does help to protect a lot of the main vital organs that we have. So if we were to look here, you can see how the liver is kind of protected by the rib cage. The stomach is somewhat protected by it. You've also got the heart, the lungs that are protected in there. You would have the spleen, the pancreas, gallbladder, and so forth. That's also housed within there. On the posterior side of that, probably just below, you're going to see the kidneys in that area too. Uh, but make sure that you pay attention to these ribs that actually connect to the sternum, and then you have your floating ribs that are there too. Uh, like just like I told you, if you come up here and feel the suprasternal notch, so you got your suprasternal notch, you come down, you're over the manubrium, where the manubrium meets the sternal body is going to be the angle of Louis, and you come out and put directly over the second rib. So the rib above that's first, so that's your first intercostal space, second intercostal space, third intercostal, and so on and so on. So that's how you would go through and count those intercostal spaces. So it's going to be important to remember that. You'll see that you have two lungs, two lobes on the left lung, three lobes on the right lung. You've got your cardiac notch that tends to sit out. You'll also notice that because of the heart sitting here, that left hemidiaphragm tends to be a little bit more displaced downward because the weight of the heart and so forth is going to kind of push it down to where the right hemidiaphragm is probably going to come up just a little bit more because there's not the weight of the heart on it that you see here. And then if we were looking at a chest x-ray, this angle right here would be the costophrenic, so where the ribs meet the diaphragm, and diaphragm being this dome-shaped uh, muscle that you see there. So important to understand the overall anatomy of, and we talked about the apex. So if you're listening to the lung apex in of itself, you could listen to that space right there between the clavicles, and then apex and work your way toward the bases. Or if you're following Egan, listen from the bases and work your way toward the apex. Left lung volume slightly less than that of the right lung. If you look at the rationale for that, we do have that heart is going to take place. There's also two lobes as opposed to three lobes over here, but you've got that cardiac notch, so the place that kind of takes, and knowing that our heart is oriented a bit to the left, is going to take up some of the space for which that air can't. So that's why the volume is going to be a little bit less um, than that of the right lung. You're gonna find I'm not trying to rush through this presentation by any means, but a lot of this stuff I've talked about already in the last chapter, so a lot of this stuff is repetitive. Looking at the exam one, there are going to be some application questions, but there's also some recall questions on there too. So it's going to be important to understand these anatomical structures. Uh, and like I said, as far as mathematics, there will come a time in this class where we're going to employ a lot of the mathematics. So if we go over a formula, it's going to be important for you to go ahead and begin to commit those formulas to memory. You're going to do a significant volume of mathematics when we get to that case study that I pass out here within the next month or so. And there will be some math that makes its way to the exams. But like I said, I've read through the first exam, and there's not really, other than components of some of the formulas that we've talked about, there's not really anything that you're going to have to manually calculate. There's one question, and if you can cut a number in half and you can do that in your head, uh that's all the math you're going to have to do on on the test. So everything else is going to be, yes, some application, but some of it's recall. So you want to make sure that you are attentive to these anatomic structures as we go through the rest of the presentation, and then really pay attention to chapter three, the mechanics of ventilation, and understand that process and how air goes in and how air comes out of lungs. But we've got two class periods that we've saved for chapter three, so we'll do that. When it talks about the dome-shaped diaphragm, it is the major muscle of ventilation. It is possible to breathe without the diaphragm as long as your other accessory muscles of ventilation are intact. However, it becomes significantly you have to think about it. You guys may have seen some of the articles about the oldest living polio survivor that lived in an iron lung, but he had trained himself to be able to come out of the iron lung. He actually worked as an attorney and so forth. He could utilize his accessory muscles of ventilation to breathe, but his diaphragm wasn't really functional. And because that's not an automatic process like the diaphragm is, like you can use your accessory muscles to breathe, but you have to constantly tell them to work on their own. They're just not going to automatically do it like we would breathe under normal circumstances. So this gentleman would have to rest himself in the iron lung. And remember, iron lung is like a non-invasive means of ventilation. If you don't know what I talk about by iron, let me show you a picture right quickly. If you ever get the chance to go over to the Carpenter Library at Baptist Hospital, I've not been in there in some time, but I do know that they had an iron lung in there. So if you ever go over to the Carpenter Library at Baptist Hospital here in Winston-Salem, North Carolina, you should be able to see an iron lung in person. Iron lung ventilator. And that's an example of what they look like. So you've got the chamber that the body will stay in. There's a diaphragm out on the end that the head would come out of. And then let's see if I can find that article right quick. The iron lung uh, ventilator survivor, survivor recent passing. I don't know if it'll come up or not. Yep, that's the guy right there. Paul Alexander. So if you want to, read about him, watch any videos about him or what have you, you can that's not him. The gentleman in the iron lung is him. So you can kind of read about him. Went on to become a lawyer, I believe, if I'm not yep, became a lawyer. That's not going to be on your test, but nonetheless, it's an interesting piece of information should you like to look it up a little bit later. We talked about the hilum. That's going to be where your arteries, veins, bronchi enter and leave the lungs. So that's there where that happens. You've got your pulmonary ligament, and that connects the lung surface itself to the diaphragm. So remember that. We talked about the left lingula, or the lingula. Yeah, it's on the left side of the heart, and that does it's the anterior portion of the left upper. So when you look here, uh, at the lingular segment or the left lingular. That's what we're talking about here. This is your hilar region, the hyaline space. And like we said, we've got those anatomical models in the not in the classroom, but in the storage closet. If you'd like to pull one out and look at it, you're certainly welcome to do that as you're studying the different segments. It would be important to know the segments based upon an illustration like this, but also the segments based upon that other model that I brought in that was just the trachea and the tracheobronchial tree coming off of that. So when you begin to talk about uh, the pleura, and let me, while I'm at home and have access to stuff, I'm gonna go grab a Ziploc bag right quick. I'll be right. Take me just a second. I'll be right back. All right, so I know that you all have probably seen a Ziploc bag before, but when we talk about the lung in of itself, you've got a parietal pleura, you have a visceral pleura. So ultimately, if you look at it, your book says that the visceral pleura lines the lung and then it folds back on itself. So if my hand inside of this bag if my hand represented the lung and this bag over my hand represents the visceral pleura, then if I were to take and kind of fold some of this bag over on itself, and if I can do it without uncovering my entire hand, maybe I should have grabbed a bigger bag. But nonetheless, we can still see that my hand is inside of that bag. It's still covered by the visceral pleura, and it says the visceral pleura folds itself back over to form the parietal pleura. So the bag lining that is out here would now cover the chest wall. So if my left hand is the chest wall and my right hand is the lung, the bag that covers my right hand is the visceral pleura. The bag that's in contact with my left, the portion of the bag that's in contact with my left hand is the parietal pleura, and there's a serous fluid in between there. They form that membrane, and that allows those to glide back and forth across each other. So the space that's formed in between the visceral pleura and the parietal pleura would be referred to as your pleural space. And there should just be a thin amount of fluid that allows those to glide over each other, just like that. So if you were to ever develop fluid in that area, or you had a pneumothorax, air would collect in that pleural space, and then that's a pneumothorax, and that begins to kind of close the lung down and so forth. But it's important to understand the pleura that we have, the visceral and the parietal pleura. Visceral pleura covers the lung. parietal pleura comes into contact with the chest wall, and the serous fluid in between the two of those allow for smooth gliding back and forth across each one of those. Uh, this shows you an anterior view and a posterior view. So with the anterior view, you can see liver, the stomach and stuff is kind of housed and protected a little bit by those lower ribs. You've definitely got the heart, the great vessels. You've got the right lung, the left lung that are there, and you can see that pleural lining of the lung covered there. And it's kind of difficult to see where it would cover the chest wall nonetheless. But if you flip the chest around, now you see the scapula, how it might be important to have the patient hug themselves if you're trying to listen to the back lungs, because if you try to listen directly over bone, that's going to muffle those sounds a little bit. So if you can have the patient give themselves a little bit of a hug, that'll slide those scapula out of the way and make it give you a bigger target to place your stethoscope to listen to those breath sounds. And then I did tell you on the posterior portion that you can see those bean-like structures. Those are your kidneys. And remember, the kidneys and the lungs are going to play a significant role in maintaining homeostasis in the body when we get to our acid-base balance a little bit later on. So you do have, and your book goes over the bucket and uh, the bucket hinge, and then like the spigot hinge, if you will, with the movement of. So just have to notice when, as we breathe, how those lungs are going to move to and how they pivot. Because we know that the posterior lung attach, or the posterior ribs attach to the spine, the anterior ribs attach to the sternum. So when you breathe, they are going to articulate with both the spine, and articulate just means move. They're going to move with the spine and the sternum. So that's essentially uh, what we want to make sure we talk about here. Let me slide that out of the way because I can't read that. So you talk about your palpable bony structures. So with that, clavicles, your collarbone, you definitely can palpate those. Suprasternal arch manubrium, you can palpate that. The angle of Alveoli, you can palpate that. The sternal body, you can palpate that. I know I'm more or less percussive on that, but you can palpate it. And you can also find the tip of that, the xiphoid process. A long time ago, they used to teach with CPR was to find the xiphoid process, place two fingers, and then hand above that. A lot of people screwed around too much trying to find that, and they were always placing their hand too low, and that would cause my contact is maybe potentially about to fall out. Sorry about that. I don't mean to keep pulling at my eye while I'm teaching. But the xiphoid process could puncture the lung, and that causes a bit of an issue. If you're looking at mid-clavicular, you find the clavicle and you go mid-clavicular line. So if we're going to go in the fifth intercostal space mid-clavicular line, you're going to find that fifth intercostal space mid-clavicular line. That's where you would find your point of maximal impulse. You just count those intercostal spaces until you get down to the fifth one. Mid-axillary, anterior axillary, posterior axillary line. So axillary is the armpit, basically. Mid axillary is going to be middle of the armpit. Anterior axillary is going to be the front of that, and then posterior is going to be behind that. So we would go with that. Uh, and then you also have, if you're going to go mid scapular on the back, those are just different anatomical regions, anatomical landmarks uh, for the purposes of how you might see a test question written or something, that is just to put you in the general area of where whatever's going on with the patient, how they want to talk about that. The pleural membranes we just discussed with the bag. Do note that the visceral pleura is going to cover the lung in of itself. The parietal pleura covers the chest wall, and these two areas, you do have a serous fluid in between the two that allow them to glide back and forth over. And those two pleura should stay pretty much in contact with each other. They really shouldn't ever be separated. Is it possible for them to become separated? It absolutely is. That's where pathology is going to come into place, whether it's a pleural effusion, whether it's a hydrothorax, hemothorax, pneumothorax, what have you. That any of those terms mean that there's something in the pleural space. The root word of that tells you what's in the pleural. If it's a pneumothorax, it's free air in the pleural space. If it's a hemothorax, there's blood. In the pleural space, and so on and so on. So those are going to be some things that you're going to hear quite often moving into the subsequent semesters and so forth too. Uh, so we'll keep that in mind. as we get into chapter three, and we'll revisit that a little more when we get to chapter three and talk about how the lungs actually move and fill with air and so forth. Um, we talked about that serous space, the thin layer of fluid. Basically, it helps lubricate those linings so the visceral and parietal pleura can glide over each other so that it doesn't generate a significant amount of friction. Because if it generated a lot of friction, then it might be painful to breathe, and we don't want breathing to be a painful. We don't want it to be a painful process. Um, Interestingly enough, and I know we'll talk about this more when we get to chapter three and maybe a bit barbaric, but you've got a couple of forces that are going to oppose ventilation. So you've got the ribs really always want to go outward. So if I could separate all the skin and take some bolt cutters or cutters or something of that nature and snip my ribs free from the sternum, my ribs have a natural tendency, not just mine, yours too, everybody's ribs have a natural tendency to want to open out like this. So they want to come open out like this. So you always have an outward pull of the rib cage. The ribs constantly are pulling outward. The lungs and of themselves, the elasticity of the lungs always have an inward recoil or an inward pull. So the ribs pull out while the lungs pull in. Uh, that's why when you take a breath in, you'll notice that the chest rises because now that you're breathing in and feel that allows those ribs to go the direction that they want to go. And then when you exhale, you'll notice the chest falls because now the lungs are pulling the direction that they want to go. They always want to recoil inward. So when it talks about this intrapleural pressure being subatmospheric, we need that to be subatmospheric so that it can facilitate spontaneous ventilation. We'll go into that in more detail when we get to chapter three. We're just introducing it here. So keep that in mind also. Uh, so looking at this chest X-ray, I know we looked at a chest X-ray a little bit ago, but we'll kind of talk about some of the things that naturally you should be able to see and some things that are drawn on this chest X-ray. So you look at exposure of an X-ray, if it's overexposed or it's underexposed, it could show up too dark, too light, or what have you. But nonetheless, you should be able to make out the spinous processes of the spine in an appropriately exposed film. You should also be able to see the entire chest on an appropriate chest film. Uh, and then again, you want to make sure that you're orienting yourself appropriately. So this L lets us know that this side over here is the patient's left side. So then that would mean this is the patient's right side. And you can see drawn in for you, there's the right upper lobe, the right middle lobe, and the right lower lobe. You can also see the tracing of the diaphragm on both sides. You have the line here, which is the separation of the left upper lobe and the left lower lobe. And then this basically shows you where the lungs would be. This outlines the trachea. The trachea you can see outlined for you here bifurcates into your left main stem bronchus and your right main stem bronchus. You can also see the aorta or the aortic arch rather with the vessels that would come off of that. You've got your superior vena cava where it's going to feed the heart. So this large object here is the heart. You can also see that there's another tube that's drawn in that may not show up as distinctly on a chest x-ray, but you can see a lot of times the stomach, and you'll notice that there's a little bit of hyperlucency here in the upper portion of the stomach or the epigastric, and that's going to be your gastric air bubble. So if you have a gastric air bubble, that is air that's in the stomach, and that air is going to go one of a couple different places. That patient's either going to have eructation and they're going to belch and burp that air out, or if that were to make its way down to the small intestine, large intestine, then they're going to pass gas and pass that air, uh, that direction as well. But it is normal to see that air bubble in the stomach. So this says this in most X-rays must be a PA radiograph due to its orientation. So the difference between AP and PA radio. So ultimately, this is likely You see, so this is likely an AP film, anterior posterior film. So ultimately, way that you can kind of look at that is a PA film, posterior anterior film, should be done in the radiology department. The overwhelming majority of the films that you're going to see in the hospital are going to be AP films or anterior posterior films because those are done on a portable X-ray machine. So when you look at the overall orientation, the orientation may not. So uh, if I go to the X-ray radiography lab and they ask me to stand with my back against the wall and they're still shooting a picture, left is still going to be over. And if I'm in an AP film, the orientation is still roughly going to be, uh, well, be this so okay, so I get what you say that with the oriented. So if I were to do that and I do a posterior anterior film, I'm now going to have to place my chest against the film and let the x-ray go through my back. It should denote if it's an AP or portable film, Faith. But my guess would be that this is an AP film, given that the left side is over here and the right side is over there. Because if I were to go here, then my left side would. You see what I'm saying? This is like you're standing directly in front of. So an AP film is like they're standing directly in front of you. So your right's going to be their left is going to be your right. Uh, and remember, if it's a PA, the best film is the PA film. Things may be a bit more magnified in an AP film because of the X-ray source. So let me look at the chat box. No, it's all good. No mistake about it. I'd rather you ask than not know. So it's all good. And I hope that made sense. Uh, close that. Um, So those are structures that we should be able to identify. Now, are we radiologists by any means? No. But there are some things that as a respiratory therapist, you should be able to look at a chest x-ray and be able to determine. And that is you should be able to find the lobes of the lungs, but more often than not, you want to make sure that you can find the trachea where it bifurcates, if there's a presence of an endotracheal tube, if that endotracheal tube is in an appropriate spot. We should also hopefully be able to pin out the cardiac silhouette or make out the heart, find the aortic arch, look at our costophrenic angles to see if we have blunted costophrenic angles to make sure that our diaphragm is nice and dome shaped or if it's flattened. I want you guys to understand, and I know this is a regular A&P class, this is a not a pathophysiology class, but if you were to get into a situation where we were to have COPD, chronic obstructive pulmonary disease. So one of the things that you're going to learn about that is you're going to get a change in the overall shape of the chest. You get a change in the AP diameter of the chest, or it takes on a barrel shape of the chest. Why does it do that? Because it's an obstructive disorder. So when the patients breathe in, they cannot completely exhale everything that they just breathed in. So every time that they take in a breath, they're constantly adding a little bit more air that can't come into their that can't come out of their chest into their chest. So that gas traps, and over time, it changes the shape of their lungs. So those individuals are constantly hyperinflated. They have more air in their lungs than what they should have. And then that trapped air in their lungs is going to give you wider rib spaces because it opens things up, but it's also going to flatten out that diaphragm, and you're going to have not as greatly sharp costophrenic angle. So it would be blunted in that angle is not sharp, but instead that diaphragm will kind of be flat across. So if you look at these x-rays over here, so you'll notice here we have blunting of the costophrenic angle there, but there's not hyperinflation that's going on. So some things that I said that we should be able to pick out. You should be able to pick out the clavicles. The clavicles are going to be indicative of if the patient is rotated or not, if those clavicles are straight across or not. If they're uneven, then the patient is rotated in the film to an extent. We should also pay attention to the trachea. The trachea should, for the most part, be midline, and then find the area of the carina where it splits into your left main stem bronchus and your right main stem bronchus. So, but now we notice there's an increase in opacity and haziness right here where the diaphragm is supposed to be. So in this case, this patient and uh, the preferred visual X-ray for pleural effusion would be the lateral decubitus film. Lateral, so if they did a lateral decubitus film, the patient's going to lie on their side, and then you can kind of see that. Also, with the pleural effusion, you're going to have something called a meniscus sign. So if you can remember from chemistry where you're reading your measurement in a graduated cylinder, where you're going to read at the level of the meniscus that's in there, the meniscus sign is associated with a pleural effusion as well. So this increase in haziness is extra fluid that has accumulated in that pleural space that we just talked about a couple slides ago. So now we've got fluid that has accumulated between the visceral and the parietal pleura. And because this patient is upright, fluid tends to settle towards the bases. So we do have a pleural effusion that's showing up down here. And how do you get rid of a pleural effusion? You do a thoracentesis. So they take a needle, they go into the pleural space, and they aspirate the fluid out. You all may even see them do that in the hospital when you go to clinical. And then hopefully, after you evacuate that fluid, the patient can aerate their lungs significantly better. So although that's not 100%, that's uh, chest X-ray B versus chest X-ray A looks quite a bit better than the first one after the thoracentesis was performed. Okay, so this concept question here, what effect would a large pleural effusion have on the pressure required to inflate the lungs? So if you go back and you look at this, and we've got lungs that should extend all the way down to the diaphragm, and they should be nice and open. So when you've got a pleural effusion that closes down a part of the lung, that does cause some atelectasis in the overall bases of the lung that can occur. So you can see it. So because of that extra pressure exerted on uh, the pleural space, it's going to require more pressure to be able to inflate that. So that's why some individuals, or not some, but a lot of individuals that have a pleural effusion will need to be treated with CPAP therapy, continuous positive airway pressure, because that will provide a little bit of extra pressure behind the breath that they're taking in to facilitate taking in a larger breath. And that positive pressure, along with diuretic therapy and so forth, can help rid the body of the excess fluid out of that chest cavity and hopefully open those lungs back up. Um, this is a little bit of repetitive of things that we've gone over before, but we do have you have a pulmonary circulation, you have a systemic circulation. In systemic circulation, arteries carry oxygenated blood, veins carry deoxygenated blood. In pulmonary circulation, arteries carry uh, deoxygenated blood while the veins carry oxygenated blood. So make sure that you remember those are flipped back and forth. Within the bronchial circulation, you do have an anastomosis that occurs. That's a connection, if you will, where you have an anatomical shunt that gets placed. So yes, I said that dead space is ventilation without perfusion, shunt is perfusion without ventilation, but ultimately you can also look at shunt too as all right, blood returns to the heart and the lungs deoxygenated, and it returns to the heart and the lungs to become oxygenated again. So anytime you have oxygen, or excuse me, anytime you have deoxygenated blood making it through the gas exchange process and no gas exchange occurred, then there is shunt. We had mentioned in the we had mentioned before. I know this isn't a neonatal class. Oops, see if I can bring it. This is not a neonatal class, but we had mentioned uh, in the heart that you have all right, so right atrium, left atrium, right ventricle, left ventricle. And we'll split those into their quadrants that they are. Remember we talked about an ASD or a VSD. We talked about, so that's an atrial septal defect or a ventricular septal defect. One of the ones that I talked about that we will cover when we get into neonatal or fetal circulation would be a PFO. So if a patient has a PFO or a patent foramen ovale or patent foramen ovale, you may hear it pronounced both ways. Ultimately, we know that we have, and I'll change colors here, we have deoxygenated blood that returns to the right side of the heart to go through circulation. And then we go, I'm just going to stop it right there. And then I'll go pink for the purposes of oxygenated blood, uh, going down the left from the left atrium up, and then we're going back out to the rest of the body. So what happens if you have a shunt? And a PFO would certainly cause a shunt. Anytime that you have a shunt and you have anatomical shunts that take place, we see that on the monitor, not the monitor, but on the PowerPoint over here where we have this anastomosis, these connections of those capillaries and vessels, where we do have an anatomical shunt that occurs. Shunt is simply when you have uh, unoxygenated blood that never gets reoxygenated and it goes back into circulation. So just to provide an example of that, if we had a PFO, patent foramen ovale or patent foramen ovale, however it's pronounced, um, in the region in which you're from in the United States, you would have deoxygenated blood that's supposed to go to the right ventricle, but some of this deoxygenated blood makes it through this hole, and this deoxygenated blood mixes with the oxygenated blood that's going to get pumped out through systemic circulation, and ultimately it lowers the overall amount of oxygen that goes through there. So we're going to learn about the P, whoops, that's an R, the PaO2, and you learn about PaO2. What's the difference between the two of those? This is the partial pressure of alveolar oxygen. Partial. So if it's a capital A in the subscript, you're looking at the alveolar oxygen. So partial pressure of alveolar oxygen. If it's a little a in the subscript, this is partial pressure of arterial oxygen. And if we look at a normal blood gas, so with a, and not to go over blood gases in significant depth because we'll do that in the future, but you do have a pH, you do have a PaCO2, you do have a PaO2, and you have a bicarb along with a base excess or base deficit, and then you'll have an SaO2 that comes about with that. Notice that when we're talking about this, how do we get a blood gas? We draw an ABG, an arterial blood gas. So we're looking at the gases within the arteries at that point. So that's why you'll see the little A that's noted there. We're not going to stick a needle in the lungs and draw a P. You'll learn about the alveolar air equation. That is something that you can calculate to determine what that is. Uh, but alveolar air should be similar to arterial, but it's not ever going to be the same. There's always going to be some type of difference, and that's actually called your alveolar alveolar PaO2 to your arterial gradient, alveolar to arterial gradient. And the reason you will always have a gradient there is because of these anatomical shunts that take place where you do have some deoxygenated blood that mixes with oxygenated blood. So P, I don't know why I keep doing an R. PaO2 is the partial pressure of oxygen you will find in the alveolus. And then uh, once we get back up here, now mind you, this is pulmonary circulation. So the pulmonary vein here is going to have this, but let's get to the point where we've gone past the heart and now we're out here in the arterial system. So then you'll have your PaO2, and I know I drew that blue. It shouldn't be blue. It should be red because it's carrying your oxygenated blood. But just to show a difference, the arteries are going to have a partial pressure of oxygen. The alveoli is going to have a partial pressure of oxygen. The alveolar pressure should be higher than that of the arterial pressure, and they never really should be the same. They should be close to one another, but they're not going to be the same because of those anatomical shunts. And shunt is simply, yes, it's perfusion without ventilation, but shunt also means anytime you have deoxygenated blood going through circulation and it mixes with other oxygenated blood, which ultimately reduces that amount. And as you go in pathophysiology, some of that verbiage should begin to make a little bit better sense. But if blood is shunted, deoxygenated blood went past the point of being reoxygenated, and it mixed with more oxygenated blood. So Why is that problematic? Let me clear this off the screen and we'll look at that. So here's the deal. If I have, all right, let's say we're breathing oxygen via nasal cannula. I think you guys have gotten far enough to know that if you're breathing in oxygen with a nasal cannula, we know that room air, the FiO2 is 0.21. We're breathing in 21% oxygen. So we know if we got a nasal cannula and we're nasal cannula at 2 liters per minute, we can estimate that that FiO2 at that point, the FiO2 estimated at 2 liters, at 1 liter you start at 24% and then you add four for every liter. So roughly we can say that this patient is breathing in 28% with 2 liters of oxygen as 28% oxygen if they're breathing in 2 liters. So we're trying to get that oxygen into the bloodstream. So we know that when we breathe in, that O2's got to uh, get to the lungs and it's got to come back out. But because of shunt, what happens is if you have this red blood cell on, and we'll just draw a box, and I'll split the box into a right half and a left half. Right box is the right heart, left box is the left heart. We know that deoxygenated blood, yeah, and we know that we should have oxygenated blood on the right side of this, and we know that this should go to the lungs, this should go to the body. In the event of this patent foramen ovale that I mentioned. So exclusively, there should be deoxygenated blood on the right side of the heart, oxygenated blood on the right side. Because of these anatomical shunts that are present within the body, you will now have deoxygenated blood that makes it through circulation and never participates in gas exchange, so it doesn't pick up any oxygen-rich blood. And then on the left side of the heart, it's going to mix with what's oxygenated. So going out to the body, there's not as much oxygenated blood as there should be. So that right there is why I don't know why I keep doing a freaking R. PaO2 not equal to PaO2. There is going to be a slight difference between the two of them. And you can calculate your alveolar air by the alveolar air equation. Uh, and you'll likely do that in your 111 class if you haven't done that already. And hopefully those concepts make pretty decent sense. And maybe it was too much. Maybe you didn't need it. If it was too much, I'm sorry. So the anatomic shunt, we talked about those bronchopulmonary arterioanastomosis. So those are connections that cause oxygenated blood to mix with deoxygenated blood and so forth. And that's what creates that alveolar to arterial oxygen tension difference or your PaO2 to. So remember the capital A is alveolar, the lowercase a is going to be arterial. We do have a lymphatic system within the lung as well. So the lymph system is going to help remove some of the extra fluid from the lungs and so forth that isn't supposed to be there. And when you can remember how much that fluid gets filtered throughout the day and so forth. So you're moving a significant volume of that fluid throughout the day. So rather than read that to you, you guys can look at that and study it and be able to remember those in case that were to show up as a uh, recall question on the test coming up. When we look at the nervous system, you guys have covered this already in pharmacology, so this should be a review. Faith, what's up?
So the PFO is an anatomical defect that causes anatomical shunting.
No, I just used the PFO as an example. Everybody has the PFO when they're born. It's supposed to close afterward, and everybody has the anatomical shunting that we had mentioned. That bronchopulmonary arterioanastomosis. Everybody has that. Everybody has a PFO, but the PFO should close. The PFO should not be a reason for shunt in an adult patient. It could be, but it should not be because that shunt should close when a baby's born. Does that make sense?
Oh, okay. So it's not supposed to be open.
No, not supposed to be. It's open in fetal circulation, but it closes after birth. to prevent that mixing of blood, or it should close after birth. It doesn't close in everybody, and sometimes it can be surgically closed with like a patch or what have you. And some individuals are able to live, with it asymptomatically or what have you. But that is a shunt that should close after it. I was just simply utilizing that as an example to discuss shunt and how you have deoxygenated blood mixing with oxygenated blood.
Okay, I'm with you.
All right, sweet.
Hmm.
Uh, Central nervous system and the peripheral nerve. So we know that the central nervous system comprises the brain and the spinal column of itself. It's pretty much the computer system for the body and how that works. We have our peripheral nervous system made up of the somatic system. That's your skeletal muscle movement. And then we have the autonomic nervous system, which is your sympathetic and parasympathetic brain. So remember, sympathetic is your fight or flight system. Parasympathetic is the rest and digest system. We also have motor and sensory nerves, your afferent and efferent nerves that work in the system. So efferent would be your motor nerve. So if I want to throw a ball, it's going to be those efferent nerves that allow me to do that. Uh, the other day, I've got a wood stove and I was putting in a piece of wood, and my afferent nerves alerted me that my hand was on fire. I mean, fortunately, it wasn't that bad. I had got my thumb a little too close to the flame when I was putting some wood in, and then the motor nerves got busy, and I pulled the hand out really quickly. So it just uh, a way to go about your nerves. And so you've got your efferent nerves, which are motor nerves, and your afferent nerves, which are your sensory nerves. This is a table that I'm going to let you go through. I know that you've gone through the neurotransmitters, the receptors in that. So easiest way, and I think you've probably already done this from pharmacology, but if you can remember what one branch of the autonomic nervous system does, whether you can memorize the sympathetic or the parasympathetic system, stimulation of the other system is going to provide the opposite effect. So just talking about heart rate and bronchodilation, sympathetic stimulation is going to cause an increase in heart rate, an increase in force of contraction, uh, and it will also cause bronchodilation, as opposed to where parasympathetic stimulation will cause a decrease in heart rate, can cause a decrease in force of contraction, and can also cause bronchoconstriction or bronchospasm, if you will. So, and you remember you've got your the autonomic nervous system is a two-junction system. So you have acetylcholine as the neurotransmitter at the preganglionic junction at both the sympathetic and parasympathetic system, but uh, and the nicotinic receptor is also at the preganglionic junction in both of those systems. But things change up when you get to the postganglionic junction. Where in the sympathetic system, you will have norepinephrine as the neurotransmitter, and then adrenergic receptors, where it's beta, alpha, dopamine, however, and then in the muscarinic receptors would be the anticholinergic, so nicotinic and muscarinic, and you still have acetylcholine at the postganglionic junction there. Do I want you to memorize this chart? No. Just to understand it, if that makes sense, Kayla. I don't think memorization of the chart is necessary, but I think it's important to understand. Let's see. All right. I I do think it's important to understand what the sympathetic and the autonomic nervous system. So this is not really comparing and contrasting parasympathetic and sympathetic. This gives you the somatic motor neuron nervous system as well as the autonomic. Just understand the somatic system is going to be involved with those skeletal muscle movements and so forth, as opposed to where we're looking. And a big difference here, you do have one synapse in the somatic system, two synapses or two ganglionic junctions in the autonomic nervous system. So I mean, I think you should read over that and be familiar with it, but I don't think it's something that would be worth committing to memory. Just because that's a big ask to remember commit that whole table to memory. Um, some of this information will be some things that yes, you will want to make sure that you commit to memory. So, for instance, C3 through 5, an easy saying for that is C3 through 5, keep me alive. The phrenic nerve is going to run through cervical vertebrae 3, 4, and 5. If you have a break anywhere between those that can sever the phrenic nerve, which is going to potentially cause paralysis to the diaphragm. If you guys can remember the original Superman, Christopher Reeves, uh, that's one, he had gotten paralyzed, had wheelchair bound and so forth, so had an issue with it kind of paralyzed his diaphragm and so forth. So we needed that. Uh, we also have nerves that are going to help stimulate those intercostal muscles. So those accessory muscles of ventilation can be uh, can be utilized as well. Uh, so when you look at the autonomic nervous system, the autonomic innervation, that it's involuntary, meaning that we when we talk so like although we can tell ourselves to breathe 20 times a minute or we can tell ourselves to breathe 10 times a minute or we can hold our breath for it, so we have voluntary control over some of our breathing. The autonomic innervation piece of that, when we talk about the smooth muscle, I can't say, all right, lungs, I need you to open up. Like if we had asthma, we could just tell our lungs to open up, everybody be chill, but they can't do that. That's where you got to take in the beta agonists, the anticholinergics, steroids if needed, because you do have autonomic innervation, that balance between the parasympathetic and sympathetic system. And if you're in a situation where those airways are closing down, then there's an imbalance, and probably the parasympathetic system is taken over quite a bit. So that's going to be important to remember from here as well. Uh, this is that two junction system that we talked about. I mean, this is a pretty good illustration. If you still have your PowerPoints from pharmacology, that's a good one to look at too. But this just basically talks about how you have your pre and post synapse or what have you with the two junction system and how the autonomic nervous system works. So you got your preganglionic junction, the postganglionic junction. You also are going to have different neurotransmitters. So at the preganglionic junction in the sympathetic and parasympathetic system, I know I'm talking fast, but this is stuff you've already supposed to have gone over. Acetylcholine and the nicotinic receptors at that preganglionic junction. The postganglionic junction is different, as opposed to here it'll be norepinephrine, and then wherever those target receptors are, those adrenergic receptors, and then the parasympathetic system will still be acetylcholine for the neurotransmitter, and you're still looking for those muscarinic and or nicotinic receptors on the parasympathetic side of the uh, nervous system. Uh, and that's a repeat of what we had said already. This chart, so was it Kayla or Carrie? Somebody asked about memorizing a chart. Let me go back and look at it. It was Kayla. So if we're gonna focus on memorizing a chart, I think this chart would be more beneficial because if you can remember what one side of it does, whether that's sympathetic stimulation on the left side, then the stimulation of the other side is going to have the opposite effect. But hopefully, because this is a chart very similar in nature to what you had in pharmacology, hopefully you've probably already got the overwhelming majority of this down, and it's not going to be brand new information that you're studying moving forward. Um, So we do have our motor responses that are included with that. You've also got those non-adrenergic or non-cholinergic receptors and so forth that are in there. So with that, we have excitatory that can allow you to help cough and clear and protect your airway, stimulate coughs, and so forth. When we talk about the adrenal medulla, so that's going to help release the norepinephrine or the nor. So this is your book calling it noradrenaline. It can so the terms can be interchangeable with norepinephrine. I know that you're familiar with norepinephrine already. So if you feel better swapping noradrenaline out with norepinephrine, 100% okay to do that. Just know if you see noradrenaline on a test, it is in reference to norepinephrine. Uh, so we do look at the beta 2 receptors causing bronchodilation. And remember, the smaller those airways get, the less cartilaginous support that they have. So you are more dependent upon uh, muscle tone for the bronchial smooth muscle that's there. Um, so if we were to have an absence of that sympathetic activity, then ultimately what's going to happen if you have no sympathetic activity, we would want to be careful because the parasympathetic system could kind of overtake things, and then we know that if the parasympathetic system were to overtake balance, that would make it extremely more extremely difficult for us to be able to breathe. We also talked, so our parasympathetic system is the cholinergic system, and it does the exact opposite of the sympathetic system. So a lot of, maybe we've mentioned this in the past, but if you have watched any type of military show, or if you've been former military, and you a combat experience or anything of that nature, that they may have tasked you with carrying an atropine pen with you while you were deployed or what have you. Why do you carry an atropine pen? Because you might come in contact with nerve gas. Nerve gas is a cholinergic agent. It's going to overload the body. It's going to cause the heart rate to drop. It's going to cause your blood pressure to drop, and it's going to make it difficult to breathe. So essentially, nerve gas causes death by asphyxiation. You basically heart gets slow enough and you quit breathing and you suffocate and pass from that. However, if you carry an atropine pen with you, which is an anticholinergic agent, we're going to stop the cholinergic process. Then the atropine pen can hopefully help if you are exposed to that nerve gas. The atropine pen in of itself can block the cholinergic response and allow the sympathetic system to kind of take over to an extent with that. So it's important to really understand the balance between sympathetic and parasympathetic nervous system. And it's also important to understand uh, when you get to pathology and so forth, why you might give somebody uh, just a straight up beta agonist, beta 2 agonist medication in straight albuterol, or you may give them a combination medication where you're given, say, Duoneb, where you have a beta agonist, beta 2 agonist medication in albuterol, but you also combine with that an anticholinergic in atropine or ipratropium bromide. You both are achieving bronchodilation, but they're doing it via two different mechanisms of action because we're understanding how the sympathetic and parasympathetic system works. So the albuterol is going to stimulate the sympathetic system to do what the sympathetic system does in opening up the airway, and the Atrovent should be given to help prevent the parasympathetic system from making it more difficult for you to breathe. So you got two different ways that you're opening up the lungs. They're just happening differently because of the choice of medication. This is another example of those ganglionic fibers where we talk about acetylcholine being at both the preganglionic junction, and you got their nicotinic receptor. You can see that listed there. And as you transmit to the postganglionic junction, you have adrenergic receptors and norepinephrine as your neurotransmitter. Down here, you have your cholinergic receptors, which could be muscarinic and or nicotinic, and then acetylcholine is the neurotransmitter at the postganglionic jump. So ultimately, this that should be massive review because you should have already covered that, hopefully, in pharmacology when you had that. This talks about the different types of muscarinic receptors that are out there, whether it's an M1, M2, M3, and so on and so on. You've also got nitric oxide that can be produced, and it'll be important later on to kind of understand. So, nitric oxide, we can give inhaled nitric oxide. That's one of the therapeutic gases that we can deliver as a respiratory therapist. That inhaled nitric oxide, or nitric oxide in general, is a pulmonary vasodilator. Remember, we talked about vasoconstriction and vasodilation. Vasoconstriction increases afterload. It's going to make it more difficult for the heart to pump. Uh, and then vasodilation would decrease afterload, make it more easy for the heart to be able to pump. So if we give uh, nitric oxide, well, nitric oxide is a specific pulmonary vasodilator. So it opens up the pulmonary vessels and makes it easier for the right heart to pump blood through there and helps with your overall PVR, your pulmonary vascular resistance, if you can remember some of that terminology that we talked about. Looking at the adrenergic receptor sites, I would go through and review this, but we've covered. So you've got alpha 1 and alpha 2. Alpha 1 are primarily within the blood vessels. They're going to lead to some vasoconstriction and so forth. So pay attention to what happens with the beta 1 stimulation, what happens with beta 2 stimulation in reference to bronchial smooth muscle tone and then vascular smooth muscle tone. There is a little bit of a difference, so you want to pay attention uh, to that. When you get to the non-adrenergic or non-cholinergic nerves, such as, so you might see some things where they look at breathing in exhaled nitric oxide. They may, so if you see a little test like this, they're testing a kid to see uh, if they're having if they're breathing out a lot of exhaled nitric oxide, because that can be indicative of asthma, as asthma is an inflammatory disease process that can be problematic. So just measure that, and that can be one of, in addition to a PFT study, that can also tell individuals if they were to happen to have asthma or not. Uh, when you get into these afferent or sensory responses, so you have something called the Herring-Brewer reflex, and that does help basically stop inflation. So it's a reflex that helps once you take a breath in, it helps to facilitate the stoppage of inflation as well. You've got those irritant receptors that are going to help with cough. So if you've ever aspirated drink or eaten a cracker or something, and you get that crumb kind of hit your airway, you begin to cough violently after that. Those are going to help with the cough reflex. And then you've got those C fibrins, or the NANC stimulatory nerves, or they're called your J receptors. Those are irritant receptors as well. And those are going to help the body trigger mechanisms to hopefully help begin to expel whatever the offending organism is that's inside of the body. Check the time. I know. I think we're getting pretty good on time. I think there's just a handful of, so maybe 15 or so more slides, but I think I should be able to speed up a little bit, uh, because some of this now becomes review from things that we've covered already. The thorax in of itself is the chest. So the thorax is the chest cavity. It's the rib cage. You've got the vertebrate on the spinal column on the back side of that, sternum on the anterior portion, and we know the diaphragm's the dome-shaped muscle that pretty much closes in the bottom of the lungs. So when you look at the cavities in the chest, you have the right pleural cavity, the left pleural cavity, and then you have the mediastinum. The mediastinum is going to take place where the heart and stuff is at. So if you were to see a mediastinal shift, it's going to kind of shift. Uh, uh, if I were to have a pleural effusion or a pneumothorax that let me see. Whoops, I didn't mean to go that far. Let me see if I can draw on the screen just to kind of show a little bit of what I'm talking about. So if I had a pneumothorax that began to fill in here, fill in that pleural space. So what's going to happen is, as that air accumulates, it's going to begin to close this lung down. As it closes that lung down, it's going to exert like that. If this is a closed pneumothorax, meaning there's no penetrating chest wound or nothing to that effect, this air cannot escape the chest cavity. So this air is just going to continue to build, and it's going to build in pressure. And now that's going to begin to shift pressure this direction. So this is going to be a situation where I get a mediastinal shift away from the affected side or from the pathology. The disease is over here. The pneumothorax is right here. And then this begins to push the mediastinum away from it. So along with that, yes, the heart may be shifted over, but it's also going to cause the trachea to shift as well. Uh, and then on the flip end of that, if I go through and take away those arrows, see if I can do that without deleting everything, and take away that line and go back up here and draw, then now let's say that this blue represents atelectasis and consolidation, where the lung has closed down. That atelectasis and consolidation, because all those alveoli close down, it almost to an extent creates a vacuum on the airways, if you will. And now those airways will change direction. Those arrows, not airways, but arrows change direction. And atelectasis pneumonia consolidation will pull the mediastinum to the affected side. So you've got pathology that will push the mediastinum. You have pathology that will pull, and I've just demonstrated through probably very poor artistic ability, um, uh, kind of how that happens. So you want to make sure that you're attentive to that as well. Clear those, and we'll keep trucking. Oh, definitely need to remember the total number of ribs. So so when you're talking about on one side of the chest, you've got 12 ribs. You may be tasked at some point in the program or asked in clinical to count the number of ribs. Well, you got to be careful on an X-ray when you're counting the rib because you're seeing the anterior and the posterior ribs. So the ribs do go around, so it's possible to count the same rib twice. So I had an individual tell me one time on one side of the chest, they're like, yeah, there's 24. Well, they counted each rib twice as they went down. So you've got to be able to pay attention where they're at the sternum or at the spine so that you don't count the same rib twice. But if you're looking uh, at those ribs. So you look at seven being attached directly to the sternum anteriorly. So when we look at those vertebrosternal ribs, seven attach anteriorly to the chest. So let me see if the next slide. So those would be the seven that attach themselves directly to uh, the sternum on the anterior portion. So those are your seven uh, 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 vertebrosternal ribs that we're talking about. And then you've got those other eight that are going to attach themselves just to cartilage. So those are going to be considered your chondral ribs or the vertebrochondral ribs. And if we look at the next slide, that's I'm pointing with my finger like you can see what I'm talking about. Those three just attach themselves to the cartilage. So they're still technically attached, but they only attach to the cartilage as opposed to where those first seven ribs are attaching directly to the sternum of itself. So those three ribs are your vertebrochondral ribs or the chondral ribs, or they're also considered your false ribs. So you see those top seven ribs are your true ribs. You got false ribs, and then 11 and 12 are floating ribs. So if you go back to that, you got floating ribs there. Notice a costal groove. So this is going to be super important. It may not mean a lot now. And let me see if no, there's not a better picture. So what I'll do is just because I've been doing it and I've got the ability to do that with the computer, I will draw a little bit on this screen. So when we talk about the costal groove, underneath each rib, and let me see if I can use a color that'll show up really well. Maybe dark green, maybe orange. Maybe orange will show up pretty well. So underneath these ribs, there's a costal groove, and in that costal groove, you will have nerves, blood vessels, and so forth that run in that costal groove. This becomes super important for you to remember because you may work at a facility that allows a respiratory therapist to perform needle decompression of a tension pneumothorax. So a tension pneumothorax is something that is very detrimental to somebody's health. If you don't fix it or relieve that pressure, they're going to die. Uh, so you may be tasked with taking uh, oops, I didn't mean to hit my computer. I have one right here. Don't really know why I have one. I don't plan on sticking it to anybody, but I do happen to have one. Um, 14 gauge angiocath. So take a 14 gauge angiocath, and if you happen to have a true tension pneumothorax, you're going to take, and if I had it, let's say it's on the left side, on my left side, I got the tension pneumothorax here. This is why palpate the intercostal space is important. You're going to go in the second intercostal space. So you're going to go right here between rib two and rib three. That's going to be the second intercostal space. You'll hold this perpendicular to the chest, and then you're going to find that intercostal space and you're going to push this needle through the chest until you hear air coming out the other end of it. And then you can put a three-way stopcock and stuff on there so that you can relieve pressure and close it so that you don't have, when the patient takes a breath, the air not going back into the chest. So let me cover that sharp object up. Just wanted to show you a 14 gauge angiocath in that regard. But where do the costal grooves and stuff come into play at? So with that, don't know what I did with my writing pen. Here it is. So when you go to stick that needle in, I'm going to change colors to black. Change colors to black. I want to make sure that I'm sticking that in the second intercostal space, mid clavicular. So I find the clavicle, middle of the clavicle, mid clavicular line, and I'm going to make sure that I stick just over the top of the bottom rib or over the top of rib three because the costal groove is underneath the rib. So if I stick this needle just below that rib, there's a decent chance I'm going to hit those blood vessels and or nerves, which can cause nerve damage and bleeding issues for the patient. However, if I stick just over the top of the bottom rib or over the top of rib 3 in that second intercostal space, then there's a highly significant chance that I'm not going to hit any of those vessels. So you want to try to stay away from that costal groove because nerves and vessels run through there. So those are definitely things that you will need to make sure that you pay attention to, not just for this class, but for the remainder of the program and for testing and in your career as a respiratory therapist. So that's why we're covering the anatomy and going over some of that stuff now. And that's just trying to provide you with a real life scenario of something to kind of expect as we get through there. Um, so we did talk about the manubrium, when we talk about the sternum, how to find the angle of Louis, how to find the overall level of the carina with chest X-ray, but through palpation, we're finding the actual angle of Louis, the second rib, and you can find your xiphoid process and so forth. So we do that. Let me see where's something in the chat box. Costal grooves follow the bottom of those ribs. That's correct. So the bottom of each rib. That's correct. So the question, if you didn't look in the chat box, question was costal grooves are at the bottom of each rib. They are at the bottom of each of those ribs. And that's where the blood vessels and the nerves are going to run. So you stand a significantly less chance of nicking one or hitting one if you go above the rib. So like we had said, I can't, it's going to be difficult so if I'm using this finger as the spine, this finger as the sternum, those ribs are going to attach and they're going to articulate to an extent, on that, and they're going to give rise. So they have the ability to move up and down, and they can, to an extent, kind of go like that, which gets us, I think, to the next slide where we talk about so we talk about articulation. So you have the bucket handle movement and then the pump handle movement that begins to occur. Both are going to happen simultaneously, and it just basically means that those ribs are hinging back, or not. I don't know if I would say hinge, but they're going to articulate. If I've got sternum and spine, they have to move like this. So it's like a bucket handle or even a pump handle, if you will, and they happen simultaneously with each other. I don't think the questions on the exam are going to be too hardcore about that, but you just have to understand rib is attached at the spine, rib is attached at the sternum, and when they move, that's kind of how they're going to move. And you can reference a pump handle of a well spigot or a bucket handle uh, of a bucket if you were to look at it in that regard. Um, with our ventilatory muscles, the primary muscles used for what would be considered quiet breathing is just breathing at rest. So when we're chilling, hanging out at rest, quiet breathing. Diaphragm, main muscle. You also have your peristernal intercostals. They're going to facilitate that a little bit, and the scalene muscles are going to facilitate some of that as well. So those are your primary muscles of ventilation, with the diaphragm being the heavy lifter in that group. Then we have our accessory muscles of ventilation. So if you have an increase in work of breathing, you've got the scalenes that are going to come activated, the sternocleidomastoid muscles that'll become activated, the pectoralis major, and the abdominal muscles. So if somebody's belly breathing or they're using their ab muscles quite a bit, you know that they're working, and they're really working to exhale at that point. You may see some of your COPD patients use pursed lip breathing where they breathe out against it, or they may actually place their arms on a table like this and get in a fixed tripod type position. And that's really going to help them get a mechanical advantage that they're utilizing those accessory muscles to help them take a breath in and to actively exhale against that. So important to understand those accessory muscles as well. With the diaphragm, you have the costal part, the crural part, and the central tendons. So just make sure that you can recognize those components, and you may have those could show up in like a recall type question. So just make sure that you go over that and review that as with an appreciation of that. So you have the central tendon that you can see there. You've got the sternal part, the costal part that we can see. Uh, and just ultimately just know that diaphragm is going to be a significant muscle. And this is introducing the parts and pieces. We'll talk more about how they work when we get to the next chapter in chapter 3, because there's going to be a significant component of that where we talk about the pressure changes that have to take effect, and the muscles involved for bringing air into the chest and getting air out of the chest. But we're just introducing those parts here. Uh, yeah. So with that, you get muscle contraction, and that's going to cause that central tendon to kind of move downward. As it goes downward, that's going to provide the movement that the ribs need uh, and help to facilitate the other contractions so that air can now begin to fill the lungs. Uh, And then you can see with that curl fiber contraction at the bottom, be important to remember that there's no real attachment to the rib, and it really only increases the vertical dimension of the thorax. So we talk about the depth, if you will, of the thorax. Okay, so when we talk about the descending movement of the diaphragm, as that diaphragm contracts, uh, and that facilitates thoracic enlargement. The thoracic enlargement occurs because, like we said, the ribs always want to go outward, lungs always want to recoil inward. But when that diaphragm contracts, it helps to facilitate the pressure changes that are gonna help fill the lungs with air. So the chest is going to rise as those lungs fill up, and the diaphragm, it says, is responsible for the subatmospheric pressure that's required to generate the tidal volume that's needed. And again, just remember, diaphragm helps to generate that. Chapter 3 is a long chapter. We've got 2 full days dedicated to chapter 3. We are going to go over that process in detail. The next time we're together in class. So we'll go just understand the diaphragm is responsible for helping to generate the subatmospheric pressure to facilitate taking that volume of air in. And so inhalation is active while exhalation should be passive. And exhalation is passive because of that natural tendency of the lungs to want to recoil inward. So for all intents and purposes, you use muscles. So you're using muscle to inhale. You shouldn't have to use a lot of muscle to exhale. If you're having to use a lot of muscle to exhale, there's something going on, and you probably have some type of breathing issue, whether lung pathology or something of that nature. Inhalation should be active under normal circumstances, while exhalation should be passive under normal circumstances as well. I talked about that change in AP diameter that you'll see with a patient that happens to have COPD. Now, I know it says emphysema here, but you have to understand that COPD is broken up into two different uh, kind of categories. You can have chronic bronchitis or emphysema that goes along with this. So notice the elongation of the chest, and you no longer have a nice sharp costophrenic angle where the lungs meet the diaphragm or where the ribs meet the diaphragm. It's kind of flattened out. You also notice there's a little bit wider spaces, and that chest cavity looks long. And if you look at the lateral view of the chest, it takes on the shape of a barrel. So you get the barrel chest the barrel shaped chest associated with this uh, um, hyperinflation. So we also know that the diaphragm needs to be able to contract and move downward. So we can have an issue where the diaphragm just doesn't have the space to be able to work with in order to be able to take a deep breath in because of the air trapping. So individuals are going to breathe probably at higher rates and smaller tidal volumes with that. Because you guys remember we talked about heart rate and stroke volume equaling cardiac output, and we want to maintain an appropriate cardiac output all the time when we're talking about the circulatory system. Well, with the lungs, we want to maintain an appropriate minute ventilation, and that's respiratory rate times tidal volume. So if your tidal volume goes down, respiratory rate has to go up. Now, you would think that, and you'll get into, and it can take another 20 minutes or so to talk about this, so I will be very brief. But if you've already gone over the PFT and the lung values, like doing your normal spirogram um, in the pathology class. So if you're looking at a normal spirogram, you're breathing a tidal volume in and out, and then you take a maximum inhalation, you fill up the lungs as full as they can, you blow out all the way till you can't no more, you come back up to normal breathing. That's your normal spirogram. With that, you've got 4 lung volumes, I'll just put LV for that, and you have four lung capacities. I'll put LC for that. So the lung capacities, you have TLC, um, your inspiratory capacity, your functional residual capacity, and your vital capacity. Those are the four. So two or more lung volumes are going to make up those capacities. So this volume here is your tidal volume. So that's the air that we're breathing in and out. Can you breathe up above that? If I take in a normal breath, can I take in more air above that? Yes, I can. That is so the volume from here to here is your IRV, your inspiratory reserve volume. At the end of a normal breath, can I blow out more if I want to? Sure. That's how I continue to keep talking and talking and talking and talking and talking without taking a breath. I can continue to talk a little bit more before I take a breath out. I continue to talk because I have a little bit of volume left in my lung, and that's called my expiratory reserve volume. So that's from here to here is expiratory reserve volume. There's also some volume down here that you never get rid of, and that's the residual volume. So you can blow all your expiratory reserve volume out. You can't blow the residual volume out. All four volumes together equal your TLC. And I don't anticipate asking you a bunch of that, but nonetheless, what happens is when we end at a normal exhalation, the volume you have left is ERV plus RV, which is your functional residual capacity. When a patient has an obstructive disorder like what you see here as an emphysema, their FRC is significantly increased. So at the end of a normal exhalation, because they have so much air trapped in their chest, they're at a greater FRC. So this is gas that will never really make it out of their lungs, so to speak. So they're going to take in much smaller tidal volumes because they only have the ability to move smaller air because of their increase in FRC. So because their tidal volume is going to be much smaller, you're going to see that you have more rapid breathing or a higher respiratory rate with the patients that have those obstructive disorders like that. So let me clear this because there's a short amount of time left and just a handful of slides left. So we'll do that. We'll take questions and I'll let you guys take your lunch break before your next class gets started. Oh, the intercostal muscle, you have your internal intercostal, you have the interosseous fibers as well. So the internal intercostals, they're going to be that they're just muscles that are going to help give rise to the ribs during inhalation. So you also have the external intercostals, and those are going to help elevate the ribs too during inhalation. So both are going to help facilitate taking air in. And remember, inhalation is active, exhalation is passive. So there should be muscle work during the inhalation process. There shouldn't be muscle work during the exhalation process. These are some perfect examples of what intercostal retractions may look like. So a patient that's really having trouble breathing, this is a little baby, you can see those intercostal, and a pediatric patient, you can see those intercostal retractions. And this is a patient that's got emphysema. You can see those intercostal retractions. This patient's breathing. Notice how he's got his hands on his legs, like I was telling you about. He's getting in a situation where he can develop a mechanical advantage. So that's a perfect example of kind of the tripod position, if you will, if you've ever read about that or heard about it. And then they're just trying to get a better mechanical advantage of their breathing. Then you've got intercostal spaces here. And you can see those because these patients are really working harder to breathe. And now inhalation and exhalation is becoming active. And you can see those intercostal spaces as the patient's really trying to, uh, not trying to, but they're having to work harder to breathe. Uh, we're getting close. We've got the scalene muscles and the sternocleidomastoid muscles. So those scalene muscles are kind of tucked in behind that large muscle right here. So I guess I could just point here as opposed to myself. So you got the sternocleidomastoid here. You've got the scalene muscles that are in there. Those are also going to help facilitate the accessory muscles of ventilation. The sternocleidomastoid muscle will help as well. And it also assists inhalation at rest, so that muscle can be involved in breathing as well. Pectoralis major muscles. are there, and you see this gentleman sitting in a tripod position as well, trying to get a little bit better mechanical advantage as he's breathing. And I would imagine that gentleman has, yes, COPD, but probably the emphysema component of COPD. I was looking at that. The abdominal muscles, those are going to help kind of force the diaphragm upward to try to help push air out of the chest. So those are really going to be help to facilitate exhalation. And you can see the patient talks about this being with COPD patients. Their outflow of air from the lungs is going to be impeded because of the obstructive nature of their airway disease. So they're going to have to utilize their abdominal muscles to generate enough pressure to be able to exhale that gas beyond the obstruction. Best way that I've found to kind of simplify that to an extent, if you look at trapped air, if you've ever played with a whoopee cushion, you blow the air into the whoopee cushion, you got that air trapped in it now because of the tapered end on it. That trapped air is going to stay in there until you sit on it. Well, if you sit on it, would be the example of us using our abdominal muscles to push that air out, and now that air is going to be able to get because you have actively compressed on that. And I'll likely utilize the whoopee cushion again a time or two in the near future over the summer, what have you, because I it to me, it makes sense, and I hope it makes sense to you all when we utilize those analogies. And sometimes I think if I can, I don't know, for me when I'm studying the stuff, if I can relate it to something else, it makes it a little easier for me to remember than trying to remember some of the verbiage from the textbook. So there's a picture of what all those muscles uh tend to look like. I mean, I know you've had anatomy, so this isn't the first time you've seen those. And that's all we got. I got a few minutes for questions if you have anything, but I know it was a massive amount of information at a pretty quick pace. I do want to ask this before you guys leave. I did record this video, and if YouTube will allow, I might upload it to YouTube. Uh, is anybody an objection to me uploading this to YouTube? If where I know your names and stuff shouldn't be brought, but I know I called on your names every once in a while, so I just wanted to ask if you had a problem with that going on YouTube. If you have if you do have a problem, tell me. And I think I missed a question by Faith. I'm sorry. Coastal Group. Oh, I did answer that one. I didn't miss it. Sorry. All right, cool. If you do have an objection, let me know, and I won't put it there. I'll just put it on Blackboard. But if you don't, I don't know if they'll allow me to put up a 3 hour video or not. But if they do, I'll put it there so it'll be easier for your viewing. Um, all right, that's cool. That's all I got. You guys are free to go. Thank you, and be safe and keep warm. You too. Thank you.